All right, ladies and gentlemen, this is County Supervisor Joe Simidian, and we are here for our regularly scheduled January meeting, 2:30 p.m. Forgive me, I think I am convening us 2 or 3 minutes late. Kudos to Supervisor Otto Lee, who was here on time and in place. Supervisor, nice to see you. I want to welcome you to our first committee hearing together, and thank you. I'm sure you'll have comments throughout because this is your first opportunity to sit in as a member of the Health and Hospital Committee. Want to encourage you to ask any questions you have along the way. If there are things that I move through more quickly than you would like, do not hesitate to simply lean in and say, hey, can we pause for a minute while you explore the topic a little bit more if you'd like. Okay? And the first item of business, of course, is this call to order. But to make it official, we'll ask the clerk to please call the roll, even though it's pretty obvious that the two members of the committee are here. So we'll turn to the clerk to call the roll and establish the presence of a quorum.
Vice Chairperson Lee.
Present.
Present. And Chairperson Simidian.
Here.
We have a quorum. Thank you.
Thank you very much. That takes us to item number 2, which is to go to public comment. Public comment, of course, is that portion of our agenda set aside for comments by members of the public on non-agendized items that are properly within the jurisdiction of the committee. Let me turn to the clerk again and ask, do we have anyone who has expressed a desire to speak under public comment?
Yes, we do.
All right. How many folks do we have, if I may ask?
We currently have one person.
All right. Well, he or she is welcome to 3 minutes, and go right ahead, please.
Thank you. Our next speaker is Audrey. Please accept the unmute. You will have 3 minutes to speak. When the timer starts, begin speaking. Thank you.
Thank you.
Hi, good afternoon. Thank you for all this time. I might not need all of it. Good afternoon. I'm Audrey Cordova. I'm a psychiatric social worker for Behavioral Health Services Department. I'm here asking for help to protect behavioral health services for children ages 0 to 5. In October 2020, Behavioral Health redesigned the assessment for intervention process, which is how children 0 to 5 enter our system of care for help. Prior to this change, we had more time to provide trauma-informed, client-centered care. The new redesign restricts us from offering people help with individual and family therapy. In our county, we want there to be no wrong door to access behavioral health services, but this new model favors short-term assessment only. It tells our consumers, congratulations, you finally got in, but there's a few more hoops to jump that may even discourage you from getting the help that you originally wanted. One parent I met had already been assessed by 8 people, and I was the 9th who would refer them on to the 10th person. This is so wrong, especially for people in an acute crisis. We have a duty to say enough is enough and stop punishing our clients because they are poor and can't afford other services where they will be treated better. Thank you.
Thank you for your comments. And I know that Supervisor Lee is aware of this, but just for members of the public, a reminder that items under public comment, because they are not agendized, may not be the basis for any formal action. However, I will ask Dr. Smith if we could ask him to have his staff give us an off-agenda memo on the topics that were just raised. Dr. Smith, is that something that we can do?
Yes, we can certainly give you an off-agenda memo.
Thank you. And for our speaker from the public and for all others, I should just mention that these off-agenda memos are public documents readily available online, and can't guarantee that anyone will agree or disagree, like or dislike the report back that we get, but I can at least offer through this process the opportunity to see what staff's response is and what they share with members of the Board of Supervisors. So I will say thank you and confirm with the clerk that there are no other speakers under public comment.
We have one more speaker.
Please.
The next speaker is Melanie. I am unmuting you. Please accept the unmute. You will have 3 minutes to speak. The timer will start when you begin speaking. Melanie, are you there?
Yes, hi, can you hear me now?
Yes, go ahead. Thank you.
Sorry about that. Good afternoon, Board of Supervisors. My name is Melanie Govin. I'm a licensed clinical social worker with Behavioral Health, Family and Children Services, and I work with children ages 0 to 5. There have been significant changes through the years. I started in 2015. 2016, our assessments increased from 4 per month to 6 to 8 a month. And then in 2018, we were informed about state requirement for network adequacy and timely access, which means that clients have to be seen within 10 business days. Then just recently, 2020, we were told our assessments would again increase from 8 to 10 assessments per month. And we would have to discontinue our treatment cases. And perhaps if we wanted to see one treatment case. Also, our parameters changed from 60 days completing the assessment and linking them to ongoing services down to 30 days. This was told to us just recently. So my concern is that our birth to 5 staff in our clinic have remained the same, meaning that there have been no increases to our staff. The support, such as the case management needs and administrative tasks, have also increased. What we're seeing are, we're seeing more challenging cases, a lot of trauma. We're seeing greater needs, scarcer resources, caregiver needs for mental health. And our assessments are powerful. It's a place where our clients can process, our caregivers, the parents process. We hold them, we link them, we explain to them what red flags are we seeing. It's not only about getting data from them and writing it as a report out, it's about making a connection with our families. It's very powerful for them. And with this increased parameter, these narrow parameters and this increased assessments, and not beefing up or equipping the staff with case management support and more birth to 5 clinicians, this is doing a disservice to our community. And, I find it important to speak up and advocate for our clients. Thank you.
Thank you.
That concludes our speakers.
Thank you. Thank you to the clerk for confirming that. That takes us then to item number 3, which is to approve the consent calendar and changes to the committee agenda, if any. I'm not aware of any proposed changes to the agenda today. Supervisor Lee, if you're amenable, I would appreciate a motion to approve the consent calendar as contained in our published agenda.
So moved to approve the consent calendar.
Thank you. I will second, and I'll turn to the clerk to see if there is anyone who wishes to speak on a consent calendar item.
There are no speakers.
Then I'll ask you to call the roll.
Vice Chairperson Lee.
Aye.
And Chairperson Simidian.
Aye.
Thank you.
Thank you. That takes us to item number 4. And Supervisor Lee, I'm guessing that you've already been informed that this is a recurring monthly consideration that our committee goes through. It is oftentimes relatively pro forma. Occasionally, however, there are some significant new developments that we take a few minutes to hear about and or lean in on. But at this point, let me go ahead and ask who is here to present on item number 4, which is in our agenda.
Good afternoon, Board of Supervisors. My name is Yvonne Karanis, and I am the president of the Enterprise Medical Staff of VMC, O'Connor, and St. Louis Hospitals. I'm here to present the credentials report, as well as the additions to the O'Connor internal medicine privileges, and answer any questions.
Thank you very much. I have no questions. If Supervisor Lee is prepared to offer a motion in support of the recommended actions A and B as contained in our published agenda at packet page 5, I would be happy to second.
Exactly, Chair, and I'm just going so moved.
All right, so we have a motion, we have a second. Thank you, Dr. Prince. Let me check with the clerk. Anyone who wishes to speak on this item?
There are no requests to speak.
All right. Dr. Karanis, okay with you if we just go ahead and do the roll call and let you get back to your other duties?
Yes, sir. Thank you so much.
All right, call the roll, please.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye.
Thank you.
Thank you. The motion passes. And thank you again, Dr. Karanis. All right, that takes us then to item number 5. Item number 5 is the report on the Child and Adolescent Psychiatric Facility on the Valley Medical Center campus. This is simply to receive a report. Supervisor Lee, this, as you may or may not know, is a particular passion of mine, trying to create some bed capacity here in the county for teens who are in a bad way. Historically, we've literally had 0 beds for youngsters and adolescents who need acute care facilities, secure acute care facilities. That has meant that we have unfortunately had to see these youngsters sent out of county, not just right next door to San Mateo County, but to places as remote as Sacramento, Sonoma County, Contra Costa County. A concern to me because we're taking these youngsters away from family and friends and their support systems at one of the toughest times in their lives. We're also taking them away from their regular caregivers who know their circumstances the best. Works a hardship on the families is I think readily apparent. And I worry, although I don't have data to support it, that some families may not seek the help that they think their youngster needs because they don't want to see that youngster removed to a remote distance. This project is designed in part to address that set of issues. Along the way, over the last half dozen years, we've been working on it. It has expanded somewhat to include additional services in the same physical facility while keeping patients' clients separate in the facility by design. As we ran into some challenges with the timeline, I asked that it be a monthly report to our board to give me the opportunity just to make sure that things were staying on track. So with all of that by way of background, and thank you to you for your patience and hearing a little bit of the history, I will turn to staff and say, what would you like to report today? Mr. Draper, I can start with you since the memo is under your name, or we can go to one of your colleagues if you like.
Well,
I see
can start off.
Please, Mr. Koenig, is that you?
Yes, it is.
All right.
Supervisor Schmidt and Supervisor Lee. I'm Doug Koenig. I'm a Deputy Director for Capital Programs in the Fleet Facilities Department, and I have responsibility for hospital projects. I'm also the designated person responsible for this project. You have the report before you. There are no significant changes since the last report. The preparation of construction documents is on schedule to be complete by the end of this month. It'll be submitted to OSHPD for review at the beginning of next month.
Right.
I would share that our contractor definitely appreciates how challenging this schedule is, and they've been pursuing several options to accelerate the construction of this project. Some of the initiatives they consider essential. One is starting early. And that may be possible. We just got some good news from OSHPD, where they have approved our request for a collaborative review process. That review process frequently results in approval of packages ahead of the regular review period, that it's possible we may get an approval for our foundation and structural package by September, October this year. So we'll see. Secondly, they're already in the process of advertising for their subcontractors to get them on board so that they'll be able to hit the ground running when we do finally get OSHPD approval. Are there any questions?
Let me see if if Supervisor Lee would like to lean in with any questions. I have a little bit of a drill I go through here every month, Supervisor. If you'd like me to go through that first, that's fine too, either way.
Sure. Thank you, Chair Smitty. Thanks for the report. As you call it, the OSHPD, which is the Office of Statewide Health Planning and Development. I want to check to see what is the next date the county is planning to meet with that group and also CDPH next.
Next date they plan to meet with OSHPD?
Excuse the interruption, Mr. Koenig. I apologize. Supervisor Lee, I could just barely hear you, even though I have the volume up at 100%. I got it, so I don't need to ask you to repeat it. But If you can make any adjustments as we go forward, that would help make sure that not only I, but staff and the public can hear loud and clear. Mr. Koenig, again, my apologies for interrupting you, but I wanted to make sure we could all hear one another. Go right ahead, sir.
Okay, I understand the question was, when's the next scheduled meeting with OSHPD? We plan to submit all of our documents electronically on February 1st, and we have our what they call the pre-submittal meeting scheduled for February 8th.
Okay.
Okay.
The good news is that things are on time and you might actually be early, you said, right?
Well, I think we were saying if we can start early, hopefully we can finish on time. The options, like I said, that the contractor are looking at are trying to start early to make it easier to meet that schedule. If we don't get that early approval, they're going to have to look at other options, which may be more difficult, potentially more expensive.
Right. Thank you, Chair. That's all the question I have.
Thank you. Mr. Koenig, just to drill down a little bit more on that. So the desire to get started a little bit earlier necessarily entails an effort to get OSHPD to sign off sooner rather than later. Did I connect the dots properly there?
Yes.
Thank you. So now I'm going to ask my standard monthly questions, which is, as I look at the document, I see that we are still planning for design completion February of 21, construction February of 22, open to patients November of 23. Do we still believe that is an achievable timeline, and are we on track to meet it?
Yes, we are.
All right. And let me ask some of the other folks. Mr. Ohashi, are you with us today?
Yes, I am.
Thank you, sir. Are we still on track to meet those that timeline, and are we capable of meeting that as things now stand?
Yes, we are.
Mr. Ohashi, sorry, couldn't hear you.
Yes, we are.
Thank you so much. And I'll ask Mr. Sodi the same question. Kamaljit Sodi?
Yes, we are on the track.
Thank you. And Mr. Sodi, forgive me, I should know by now. Am I pronouncing your last name correctly, sir?
Yes, sir. Yes, sir.
Thank you.
Thank you.
Thank you. No, I've listened to Samidi and be mangled all these years. I try to get other people's names right if I can. Paul Lorenz, are you with us?
Yes, sir.
Thanks. Can I ask if we're still on track to meet the timeline as contained in packet page 32 of our report today?
We are on schedule. Yes.
All right. Jeff Draper, are you with us today? And can I ask you the same question, sir? Apparently not. Dr. Smith, are we on path to and track to meet the timeline that is shared with us at packet page 32 today?
Yes, we're on time.
All right. And thank you, Dr. Smith, and thank you all for the effort to keep us on track and on task. And always a pleasure to hear good news from OSHPD. That's a welcome piece of data. Mr. Koenig, let me just ask, my recollection is that we're going to do a little bit more of a show and tell on this at our February meeting of this committee. Is that your understanding as well?
Yes, it is.
Okay, good. We'll plan on that then a little bit. Think of it as your coming out party, all right? That may be an antiquated phrase if ever there was one.
Okay,
all right.
I think.
Go ahead.
No, I was just going to say, I think we were talking on the second meeting in February is what we've scheduled.
Okay. Then I will ask Michaela Hellman-Tincher from our office to call with a quick question after we get out of the meeting later today, Mr. Koenig. So if you can keep your eyes and your ears open for a call from her or an email from her, just a quick piece of data to exchange. Okay. Thank you again, Supervisor Lee. I would gratefully receive a motion to approve the recommended action, which is simply to receive the report on item number 5.
Yes, so move, Chair.
All right, motion by Supervisor Lee, second by me, Supervisor Simidian, for the record. Let me check with the clerk, see if we have anyone who wants to speak on this item.
There are no requests to speak.
And if we could ask you to call the roll, please.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye.
Thank you.
Motion carries 2-0. Thank you again to all the folks who are making this thing happen. Appreciate it. That takes us to item number 6. Item number 6, of course, is the report from our public health office and administration on public health matters, but specifically COVID-19, of course, which is consuming us all. So Dr. Smith or Dr. Cody, who would like to begin?
Good afternoon, Supervisor Simidian and Supervisor Lee. I will present if I can figure out how to share the screen, and then a number of us will be available to answer questions and engage in discussion. I'm here with Dr. Fensterscheid, and of course, Dr. Smith and others are online as well. So I am not, there we go. Can you see my screen?
Indeed.
Okay. So this is a brief update, and I'm going to cover both an update on the epidemiology, as I usually do at full board meetings, as well as touch a little bit on the new variant that's been in the news, what we know and what we don't, and what it may or may not mean. And then we'll move to an update on the vaccination rollout here in Santa Clara County. So to ground us all in where we are in the epidemic, as you know, we have been experiencing an explosive surge. We are just starting to see some early signs that maybe we're going to now trend, either flatten out or trend down. I would caution that these are early signs, and it's a little too soon to call it, but we try to remain hopeful. As you can see, the average number of new cases a day has been north of 1,400, which is, far and above anything we have seen in any previous peak. Our hospitals in the December and January have seen over 3 times the number of patients that they had to care for in our last peak in the summer. Interestingly, this curve, as you can see, has already started to trend down. Generally, you see the cases trend down before the hospitalizations, but here we have the hospitalizations trending down. So that's good news in that they're beginning to soften, but I would temper it by saying that the number of COVID patients in the hospital today is still over 3 times what we had during our peak in the summer. So the hospitals are still quite stretched. And our deaths, as you know, the deaths from COVID lag behind the new cases and the hospitalizations. And so unfortunately, we expect to see many more deaths in the weeks to come. And right now, as you can see, in these first few weeks of January, we have had over 100 deaths per week with COVID reported here in Santa Clara County. And we passed the 1,000 COVID death mark a little bit ago and continue to see many deaths reported each day. And I would also say that in the United States, as you know, the United States today passed the 400,000 Americans who have died of COVID. So among the many things going on with COVID, there's now been a lot of news coverage about various different variants circulating. And so I wanted to just step back and talk a little bit about the variant that was in the news over the weekend that at the moment is being called the 452R variant, but I'm sure if this variant turns out to be of significance and of importance, probably will get a new name. But just remember that the the SARS-CoV-2 virus, it's an RNA virus, and RNA viruses adapt and change because their job is to become fit and to infect as many hosts as possible. So this SARS-CoV-2 virus does adapt and change a lot. So to some extent, this is expected. So there's lots of different variants circulating, many different variants circulating. The way to understand what's happening is you have to do genomic sequencing in order to identify them. And that's how you identify, this one particular flavor of the virus seems to be becoming more common. And so this particular variant, which we're now calling the 452R variant, does seem to be more common as compared to a few months ago. But I just want to caution that in the United States and in California, there is not a population-based surveillance system. In other words, it's not as though there's a standardized system where everyone is doing sequencing and looking at and identifying the variants. Rather, it's more of a convenience sample. And so where you look, you may find, but not everyone's looking. I would say that's the top level message. In Santa Clara County, our public health department, we have submitted more samples for sequencing. In other words, done more looking than pretty much any other jurisdiction. Therefore, we're doing more finding. So I wanted to just sort of put some context around the finding that we're seeing this variant frequently here in Santa Clara County. Part of it has to do with the fact that we're doing more looking. So as we've looked and had the specimens from our county sequenced, we have identified this variant, and it's been identified in a number of different settings, including from large outbreaks in long-term care facilities, as well as in other settings, and as well as in the community from samples that we test through the community. So that's all I'm going to say about the variant, but I just wanted to give a little background and context in case there's further questions. Now, turning to vaccine, some of this we discussed at a board meeting, but I really think that we can't emphasize enough the context in which we in Santa Clara County are rolling out the vaccination program. Since the beginning, the state and federal guidance has been continually changing. And we don't anticipate that is going to change. And certainly with a new federal administration coming in tomorrow, we expect the federal guidance will change, and we anticipate the state guidance will likely change as well. Another continual challenge is that the vaccine availability in the near, medium, and long term is largely unknown. So as far as being able to plan ahead, it's impossible. We cannot anticipate the amount of vaccine coming into the county, and therefore can't plan. We can take a best guess. And finally, the vaccine allocation and distribution system is extraordinarily complex. And locally, the county and the public health department, we control only a portion of the allocation to the health systems in our county. So that's the environment in which we are working. There have been a few recent announcements regarding allocation. One is, you may remember that it was in the news that the federal government had announced that all the current stockpiles would be allocated to states immediately. So states were anticipating that there would be a significant influx of vaccine supply. But then a bit later, it was announced that, well, actually, no stockpile exists. And so we're still in the situation where the incoming vaccine supply is still unknown. There was also an announcement that the complexity of allocations for first doses and allocations for second doses is becoming extraordinarily complicated, and therefore likely that future allocations will not distinguish between a first and second dose. They'll simply be an allocation. So this diagram, again, one that many of you have seen before, paints a picture of, sort of at a high level, of the complexity that we see at the local level. So Santa Clara County, our local vaccine providers in the orange box, are receiving vaccine from 3 main streams. So the federal government will do direct allocations, for example, to the pharmacy partnership with CVS and Walgreens, as well as directly to federal entities such as the VA hospital. So we don't see those, and we don't have any visibility into those allocations at all, even though they're being allocated for residents living in our county. Through the state, the federal government also makes an allocation to the state, and the state allocates in 2 big tranches, one to multi-county entities and one to county health departments. We have 2 large multi-county entities in our county, Palo Alto Medical Foundation and Kaiser. They both receive allocations through their organization, and then it comes locally to the hospital and clinics operating in the county. So the vaccine allocation over which we have control and complete visibility is the vaccine that comes to the county, which we then allocate both to the county health system as well as to some other providers. So what we have done, yes, I'll tell you a little bit more about what do we know about this week, because these allocations, as I've explained, are something like just in time. The allocation for this week, and these I can confirm that this vaccine did arrive today, a little over 29,000 doses total, which was a combination of both Pfizer and Moderna, and it was a combination, the Pfizer doses, some first dose allocation and some second dose allocation. And you can see there the allocation that the county received in the context of the allocation.
Excuse the interruption, Dr. Cody. I wonder if you could pause and perhaps revisit this. The first dose Pfizer, 6th allocation, the second dose Pfizer, 3rd allocation, the first dose Moderna, 5th allocation plus today. Could you kind of bottom line this a little bit for us? And again, forgive the interruption, but I'm having trouble keeping track here.
Right. So that is the bottom line, the main takeaway. It is difficult to keep track. You hit the nail on the head. So this is a simplification, but perhaps it's still too much information. The bottom line is that once a week, the county receives vaccine. The vaccine that we receive is usually part Pfizer and part Moderna, and it's usually part first dose and part second dose. So it's allocated by vaccine and by whether it's a first or second dose. So this sort of breaks it out and summarizes it.
And does the number, forgive the interruption again, but just to question, does the number on the right-hand side of this display, 29,350 doses total, mean that if I were to say, okay, Pfizer and Moderna, from the very first dose we've received right up until the moment today, whether it's a first dose or a second dose, all of that totals 29,350 doses? No.
This is the doses received this week. It is not the cumulative doses received so far.
Okay, that's why it says this week's vaccine allocation, but the dose at top, but the doses total, it's a doses total for this week, not for the date, because those numbers certainly didn't add up to what we've been hearing before, which is why I was confused. Okay.
Yeah, that's correct. That's just a snapshot into this week.
Got it.
Correct.
Thank you.
You're welcome. This is simply a screenshot of what's now up on our county website that shows the vaccine doses by provider. This is a lot of detailed information here, but I show it for 2 reasons. One, to ensure the public knows that this information is available on the website. And 2, just to point out a few different things. The entities there that are not grayed out, those are the ones where the county is the source of the vaccine allocation. So back in the overview slide, everyone in blue is showing up here in white. And you can see what first doses they've received, how many they've reported to us that they've administered, and same for second doses received and second doses administered. And then next you see, next you see our two multi-county entities, Kaiser and Palo Alto Medical Foundation. Kaiser is reporting to us the doses that they've received as well as the doses they've administered. Palo Alto Medical Foundation has stated that they are sending, but we have not yet received those data. And then the final three, CVS, Walgreens, Indian Health Center, and the VA, are federal entities not required to report to us, but may ultimately report to us anyway. We just simply don't have those data yet. Another comment I wanted to make, and I'm sure you'll have many questions about this slide, is that sometimes there are more doses administered than received. That happens because the vials, you can actually get more doses out of each vial. So you can administer more doses than you receive. I also think I want to point out, and it's really important to know about the appointment scheduled within the next 7 days, because what we really want to understand is, are the doses are allocated to us and distributed, but we really want to know, does each one of those doses, do they correspond to an appointment with a patient? That's what's important, not really what's sitting in the freezer at the moment. And I think of it kind of like if you go grocery shopping, on a Sunday and your fridge is full of food, someone could come to your house and look in your fridge and say, wow, look at all that food, you're wasting all that food. But the point is that you have that planned out for your meals for the week. And so what's important to know is what food or what vaccine do you have and what's the plan for it? And that's what's really important. And that's what we're attempting to get at with that final column of appointments scheduled within the next 7 days. We have now a shortcut to get to all of this vaccine information, scc.freevax.org, and that brings you to the vaccine portion of the COVID-19 website. And there, members of the public can both get links to their medical home, Kaiser or PAMP, Stanford, the county, or what have you, as well as get more information about the vaccine. So that's concludes the presentation, and I'm sure there are many of us on here who would be happy to answer questions that you may have.
All right. Supervisor Lee, I'm going to let you go first, and then I'll follow up with my own questions, and then if that prompts an additional follow-up from you, happy to accommodate that. But why don't we start with you and your comments or questions? Go right ahead.
Thank you, Supervisor Median. Thank you, Dr. Cody, for the report, and of course the good news that we actually did get about close to 30,000 doses today, which, given the fact that I think we are now up to about 6,000 vaccinations per day is our throughput. That would last us only about a week, correct?
A little louder if you can, Supervisor. I apologize.
Dr. Cody, could you hear me?
Yes, I can hear you.
Oh, good. So my question was, what we just got, which is about 30,000 doses, based on the fact that we're about 6,000 a day, this would only last about 1 week of vaccinations, correct? Roughly.
That's correct. And I invite Dr. Smith or Paul Lorenz also, who may be closer to the operations. But that's about right.
That is right. We do have some vaccine left that wasn't received today, but you're right. Basically, if we don't get vaccine on an ongoing basis, we will run out usually about 7 to 10 days from now.
Great, thank you. And I would like to say, first of all, thank you very much for getting the dashboard for the vaccines up just last week. I find it to be certainly very helpful. And it's unfortunate that in this case, one of the organization, PAMP, has not been able to report yet, but in any case, I spoke with some representative from Kaiser last week, and they actually mentioned that when they were running out of vaccine, they have asked our county for help, and we have been able to provide a few thousand dosage. So I just want to double check because that's normally not the way it works, right? Because we're only supposed to support our county groups, and Kaiser and PAMS are supposed to get it from this multi-county group, correct?
That's correct. In our county, Kaiser didn't have enough vaccine to vaccinate many of their phase 1A populations, and so we did give them a few thousand doses. I understand there's a similar situation in other counties where the county allocated from the county supply over to Kaiser, a multi-county entity. I think you will notice if you look back at that rather complex table that's now up on the website that, you know, remember that Kaiser serves about a third of patients in our county, and that they received, you know, really a much smaller fraction of vaccine. But the bottleneck is the distribution system from the state to the Kaiser mothership down to the Kaisers here. And as I mentioned earlier, we have no visibility into that pipeline.
Right, exactly. And I think we barely talked about the issue of the total asset visibility, and that's exactly what we don't have, unfortunately.
Yes. We have total asset obscurity, yes.
Obscurity. Now, so based on today's number on the chart that you provided earlier, looks like the state got about close to 750,000 doses for the entire state of California, right? And then of that, we got 30,000 of it, approximately, right?
I didn't add up that number, but if you did, I trust you.
Yeah, okay, good. So, I mean, it just shows how slow things are, unfortunately, right? Because obviously, us being the largest state in the United States in terms of population, 750,000 doses is a small number for a state of, close to 40 million people. It looks like truly the bottleneck here is the supply from the federal government coming to us, and that's what we'll need to hopefully increase that supply down the road. And like as you said, with the new administration coming in, we hope that there'll be further. I mean, there'll be changes, there'll be different guidance, but hopefully they would be able to push forward quicker on these different type of vaccines. One story I just heard too is apparently there's one batch of Moderna vaccine that's been held back due to some side reactions. I don't. Is that affecting us also, or how big a number are we talking about?
Yes, there was one lot of Moderna that out of an abundance of caution was withheld. And this is because one site in Southern California had an unusual number of reactions. So there's a pause in the distribution of that lot while they investigate. And it did impact our county, and I am looking for the numbers. We had a little over 21,000 of those Moderna doses that came to our county. They had been slated for both our county system as well as Stanford and El Camino Hospital. None of those doses from those lot had been given, and so they've all been paused.
Right, until we could get further guidance that until they're cleared, obviously, those will not be usable for now.
That's correct. That's correct.
Okay, great. And I just want to say again, thank you for the great work our team has put together, and it's really an amazing logistical challenge. Actually, right before this meeting, I was actually over at the fairgrounds assisting since my parents were just scheduled to get their shot this morning. And frankly, I would say is a very smooth operation, and learning that morning seems to be also busier times. Things kind of quiet down, like by the time it gets around noon or so. So there's certainly up and flow, but it seems like people were able to get everything done very orderly, and the 15-minute wait time was very well used by allowing people to schedule the second dosage. And I just want to say thank you for the team for the great work you guys are doing for our county.
Thank you, Supervisor Lee, Dr. Cody, Dr. Smith, and team. I have a number of questions as well. Let me start with what I think is a very tough one, which is if I'm crunching the numbers correctly, I'm looking at Kaiser having responsibility for probably 30% of the patients in the county. I think Dr. Cody said maybe a third. Sutter/Palo Alto Medical Foundation, maybe 21%. So, clearly half the county. My numbers indicate 17% at Stanford and their affiliated systems, and then our own county directly responsible in terms of the patients we serve for 15%. Those four, I'll just call the big four, taken together are probably something like 85% of the population. Dr. Cody, Dr. Smith, does that sound right to you all?
That's about right, yes.
Okay, so the follow-up question is, we're fortunate, and it's not just good fortune and relative prosperity. It's been a concerted effort that we have so many folks in our county who have insurance and a healthcare provider. But I'm curious, at the county facilities, how are we going to deal with folks who are the patients of Kaiser or Sutter/PAMF if they show up and ask for the vaccine? We've gotten what I'd call mixed reports, at least my office and I have, news accounts of phone systems that are backed up for hours on end and computer systems crashing. On the other hand, I've got somebody who just within the last 24 hours made a point of emailing me to let me know what a good experience they had getting their vaccine. So I'm wondering if we're setting up sites around the county, and we are, and we're partnering with community clinics, and we are, what happens if somebody who is, quote, supposed to go to Kaiser or PAMF, or for that matter, Stanford or some other system, shows up at one of our sites?
Well, Supervisor, I put up online here what you'll find at sccfreevax.org. And you can see that we have a table which goes through all of the major providers and lists who's eligible, gives you a connection to schedule an appointment. Some of them have phones, some of them the appointments are scheduled online. All of the appointment structure is intended to direct people to the provider that they utilize themselves, and therefore they're discouraged from using other providers. But if somebody shows up at, say, a county clinic and they are covered by Kaiser, we encourage them to call back and go to Kaiser, because, as you know, we have limited supplies, and the supplies are allocated separately between Kaiser, the county, and Palo Alto Medical Foundation.
Dr. Smith, I'm gonna press the point a little bit here, just because I think we do need absolute clarity on this. It strikes me that there aren't any good answers here, so I don't want you to think I'm looking for one where it doesn't exist. I'm inferring from what you're saying that essentially, the county's position is, look, we're only getting half the vaccine, and we have to distribute much of that to other providers. Kaiser and Palo Alto Medical Foundation /Sutter are getting half the vaccine, so we can't take on the burden of providing the vaccine for their patients. Is that basically the challenge? Because if we use the limited amount of vaccine we have for their patients, then we're left with insufficient vaccine for our patients, yes?
Yes, that's the basics of it.
The downside, of course, is we're telling, Santa Clara County residents and taxpayers that they are unable to access the vaccine from quote unquote their county. There's no way around that. I mean, is that an accurate statement?
Yes, it is.
Okay. I think it's going to be helpful and important to explain in as simple a language as you possibly can that is the county's protocol and why it is the county's protocol. I think people can understand, look, the vaccine has been distributed directly to your healthcare provider, and therefore, our county organization, I think this is the protocol rationale, therefore the county organization can't provide vaccine for patients of those two systems without then being at a loss to meet its own obligation to its own regular patients. Have I restated that correctly a second time?
Yes, that's correct.
Okay. I think this is going to be a little confusing and disconcerting to people. And I also think, as I say, there's no good answer. We went through this with testing, as I'm sure everybody will recall painfully, because we were hard pressed to take our testing efforts to scale without the participation of these other healthcare organizations. And I'm hopeful that after we work out the initial challenges in the system, that everybody's going to be in a position to provide the vaccine to quote their patients within their system. But it sounds to me like that may be a challenge up front. We'll see. Dr. Cody referenced the fact that we still don't have information for the dashboard from Sutter/PAMF, but that we're hopeful we'll get it. Is that anything else you want to share there?
Well, we've been in informal conversations, and we've also told them formally that they need to produce the data now.
And Dr. Cody, is there, my recollection of your public health order, and thank you again for the prompt issuance of the order, is that come February 1st, this will be required by virtue of the order, yes?
The February 1st date pertains to the plan that healthcare systems are to submit to the county. They are already to be submitting data. And so that is why we've already been following up with PAMF regarding data. Yeah.
Thank you. That distinction had been lost on me. So thank you for clarifying it. So does that mean, and I'll look to County Council, I guess it's Mr. Press, does that mean that obligation already exists by virtue of an existing public health order, and that if there isn't follow-up on a timely basis, that folks are subject to fines or penalties under the ordinance passed by the board?
Yes.
All right. Well, I know the goal is that it not come to that, but I do think it's useful to know that, and want to give everybody the benefit of the doubt, but I think we all know that time is of the essence. And forgive me, I'm looking at my notes. Couple of items on the web page, website rather. I think first, I'm sure it must seem like a chore, but I can't tell you how often I hear from constituents, just anecdotally, how much they appreciate access to the information. Second, I think absent such a site that's really robust and well-developed, we would be fielding an even greater number of inquiries than we are as an organization, and that would be a challenge. the last thing I'll say is I appreciated the note, and I think it was the San Francisco Chronicle on Sunday that described our county as one of the most transparent in terms of providing the information, and that's important. Not if for no other reason than I think in order to be effective in our work, we need to maintain the public trust. And in order to maintain the public trust, we do need to be as fully transparent as we possibly can be and provide the information. And so I just want to say, I appreciate the fact that there's a cadre of folks who are out there trying to make sure we provide this information well. To that end, thank you, Dr. Cody, for explaining how people could give more doses than they received. That was one of my questions. I was baffled by that. And I do note that at the bottom of that page, there's sort of reference or an explanation of that. I would, because I know you have scores, if not hundreds, of folks who are trying to improve the web presence, the online presence, but I do think maybe an asterisk to that information. So if anybody is looking, they can connect the dots, which I found not readily apparent. And I know my own office has been in touch about adding information. And I think this is important for how folks can access the vaccine if they have mobility issues, disability issues at all. And also, I think it's probably helpful and important to make sure we're very clear about the fact that there are nurses at all the sites to monitor in case there is an adverse reaction. I think that might give some comfort to folks and in so doing, increase the number of folks who come through the system. From the start of this, and Supervisor Lee, I'm sure you're finding your own path and priorities. Each of us as supervisors has I think taken on sort of different pieces of this challenge to focus on. For me, they have been 3 since March, and I would say they were testing, system capacity, and now vaccines. The system capacity and the need to surge is something that I think our staff has been very mindful of and is experienced at managing, and I know it's a major challenge, so thank you for that. Testing, I thought that like most of the state and the nation, we were slower to ramp up on testing, in part based on representations from the federal government that turned out not to materialize. But I do think that that was an effort where, I wish we could have been faster. Ultimately, we got to a much, much better place. Thank you for that. And of course, now we're on the issue of vaccines, and that continues to be a focus in terms of moving it out. I wonder if staff could talk a little bit about the fact that, in the last week or so, we've had changing priorities and protocols, and even within our county, if I understand it correctly, Kaiser said, if you're 65 and above, come on in. Even as Sutter was saying, no, you have to be 75 and above. And so, as you might imagine, I've heard from constituents who say, I don't understand why my next door neighbor can access the vaccine, but I can't. Thoughts?
Yes, this has been extraordinarily challenging on the local level to manage expectations and have clear and consistent communication when all around us the guidance is changing. And so you may have noted when Dr. Smith pulled up the vaccine webpage that describes which health system is in which phase of offering vaccine, that Kaiser now is offering to 75 and up, consistent with other health systems. So it was also a concern, of course, because we know that Kaiser is receiving just a trickle of vaccine as a multi-county entity, and yet with the announcement at the state level of expanding to 65, Kaiser in general fell in line. But of course, our local Kaiser did not have the vaccine to be able to vaccinate that population, and created a lot of frustration. So what we are here to do is to the best of our ability, make transparent and clear what the context is, and continue to try to make the the guidelines available. I will say that we have transitioned from where we were told that these are the guidelines and you must follow them, to now these are the guidelines, they're changing a lot, and each healthcare system must do their best to implement them. So our job is to implement them within the county health system, but not to implement them for other systems, which is a significant difference than how we started.
Okay. Let me. Well, so for the moment, we have what appear to be more or less relatively consistent criteria between or among Sutter, Kaiser, and our county operation, but there's no guarantee that that will be the case a week from now or 2 weeks from now. I don't mean that in a chastising way. I'm just trying to be realistic about what the future looks like for us.
That is true, and I also cannot highlight enough, while we're all at the moment we're in the same place of the phases, but the vaccine supply is extraordinarily limited into the county, and it is different between the systems, as you can see in that table on the web.
Do we know that the supply for Santa Clara County at Kaiser is limited? Or is it possible that Kaiser has received a significant supply but has simply chosen to send the bulk of it to other counties for whatever reasons they might have?
As I mentioned when reviewing that chart, the areas of gray on slide number 9, we have no visibility. So we don't know what Kaiser has been allocated, nor what Kaiser has allocated to each hospital and clinic within the system.
All right. Thank you for that. Dr. Cody, Dr. Smith, I know you will both recall that month and a half ago when we were first preparing our plan for the county, I expressed concern about the fact that there were not county clinics or hospitals available for vaccine distribution in the 5th district that I represent, the northwest portion of the county, and have been exhorting folks to find a distribution center there. We're up and running at the fairgrounds, and we're up and running at Berger, yes?
Yes, we are.
And it's my understanding, and I just want to surface this publicly to get confirmation, that we're hoping that by this Friday, coming up in 3 days, that we'll have a facility in cooperation with the City of Mountain View at the Mountain View Community Center in Mountain View, yes?
Yes, at this point, we're confident that we'll have it up and running, and the appointments will be able to be made late evening on Wednesday, so tomorrow.
Okay, so, and the appointments would be going through sccfreevax.org, yes?
Right.
Okay. And
maybe I can add just a little bit more information.
Yeah, please do. Thank you.
On Friday, we will start with a smaller number of appointments than we plan on the long run. In next week and weeks going forward, presuming we have enough vaccine, we'd like to schedule somewhere in the 500 to 1,000 range number of appointments. On Friday, we're going to start with more like 150, basically to work out the kinks in the process. But all of this depends on having adequate vaccine. Today, we had 6,000 appointments scheduled throughout the entire county system. And as Supervisor Lee pointed out, at that rate, we will run out of vaccine quickly unless we can get some more from the state. So we're confident that we'll be able to get Friday started, and we'll expand next week.
And forgive me, my audio fritzed out for just a minute when you were saying 150 is the start, but the hope and expectation is that our typical daily rate will quickly move up to what again, please, in Mountain View?
Between 500 and 1,000.
Thank you. It was just a glitch in the system here. And Dr. Smith, to go back to the earlier conversation we had, first, thank you to everybody for making that possible so that there's a regional center there in the northwestern part of the county. Second, that being said, while we can accommodate, we hope, significant numbers on a daily basis pretty quickly, again, for folks, because this is going to be important in terms of communicating to the public, for folks who get their health care from Kaiser or Sutter or Stanford, we're going to continue to ask them to go to their regular provider for their vaccine, yes?
Yes, we are.
Okay. And Dr. Smith, I have shared with you previously, and Dr. Cody, I can't remember if we've talked about this, forgive me, the fact that we get some folks who say, can't we just have a phone number if we're not adept online? There are phone numbers, as I recall, but the phone numbers are, and the phone numbers, ironically enough, of course, are available online if you go to SCC Free Vax. Is that the plan, Dr. Smith?
Yes, that's the plan. It's a different contact for each health system.
Well, there's nothing that prevents us from sharing that information that's available online if we want to put it out in print to let people know how they can simply pick up the phone if going online is a challenge for them. Yes?
Sure. Correct.
Okay. Could you give us an update on, and forgive me if I missed it earlier in the report, I don't think it was there, what happened to what I call the rogue link to the vaccination appointment sign up that we talked about at a prior meeting?
We think that we have cured that problem. Basically, what was going on was that there was a link provided between our system and the state, federal system, and people were taking a picture of that with their phones and then spreading that picture to others, which gave them a way of getting past the original questions and answers. So we've changed the access that way so that at this point, we're not aware of anybody being able to take a picture of it and move on.
Thank you for that. We had talked, and I want to revisit this. We talked a little bit about, do we have any ability to persuade the state that we are in need of and could actually use and dispense more vaccine if we think we are in a position to dispense more vaccine through our available channels?
We certainly could dispense more vaccine. I'll let Marty answer the question about how to persuade the state.
Dr. Fensterscheib, they saved the easy question for you, sir.
And Dr. Fensterscheib stepped out. So let me just say that when I speak with colleagues around the state, every single health official in the state, or almost every single one, is hampered by short supply. I think that it may look statewide as though we are, quote, sitting on vaccine. My sense is that it's largely a vaccine accounting problem, not that the vaccines aren't actually flowing out into operational clinics. I can't speak for other counties. I know in our county, you could look at it and say, gosh, you've received this many doses and only this many have been administered. But in general, the big challenge across the state is supply, not enough supply. And I think that there's not enough supply from the federal level to the state and not enough supply from the state level to the counties. I think that's the core issue.
And for constituents, Dr. Cody, who are asking, why aren't we at 65, which we were getting a lot of questions on, in my office when Kaiser announced 65. That may abate now that they've gone back to 75. Is the short but accurate answer, there just isn't enough vaccine yet to accommodate that large swath of the population?
That is correct.
Okay. And
I think you
this
should
race,
also,
go ahead, I'm sorry, forgive me, doctor.
I was going to say, we should also point out, just for clarity, because both of these vaccines require 2 doses roughly a month apart, and that distribution was structured such that you get first doses and second doses so that they match up. So when you look at the accounting, the inventory, sometimes the second dose looks like it's excess inventory when in reality it's already committed to the person who got the first dose. So that's part of the reason why it looks like there's more vaccine available than there is.
Okay, thank you. That you anticipated my question, Dr. Smith, which was, how does this play into the first dose, second dose conversation / confusion that we've been having? And there's been quite a bit of concern and I think confusion about the issue of spoilage. Has that in fact been an issue at all in our county?
Not really, no. I think that most systems have been extraordinarily careful to plan, overbook when necessary so that they use up all the vaccine that they have. That's not to say that there's never been a wasted dose across the county. I'm sure there must have been, but I think my understanding is that it's been quite minimal.
Thank you. Slight shift in questions, and I'm just about to wrap up here. Supervisor Lee, if you have any follow-up as well. There was there's been some discussion both in our meetings and also in the press about the fact that not all healthcare personnel were inclined to access the vaccine when it was made available. What's the follow-up then in terms of their continued work in our system, even though they are not the beneficiaries of the vaccine? Do they keep working on their regular jobs? What are the tensions there? There must be some.
I can probably jump in on that one. Well, maybe not so obviously. The county doesn't have the authority or right to compel someone to get a vaccine. However, we do have the responsibility to make sure that people who work with patients and with other employees are protected. So on an individual, one-by-one basis, we assess what their job description is and what they're able to do safely and make sure that we assign that appropriately. Probably the place where this is most significant is in the jail. And the sheriff has adopted the policy that there will be testing, and the testing will be daily using the quick testing. And once there's sufficient vaccine, there will be vaccinations of staff. And if staff are unwilling now to get tested, they are reassigned to a different job, or they're asked to take leave, vacation leave themselves. When it gets to be vaccine time, something similar will happen.
Okay. I think that's it for me, at least for the moment. I'm going to go back to Supervisor Lee here in a second, except to say, Dr. Cody, you're still on the line, yes?
Yes, I'm still here.
And Dr. Smith, I see you're still here, at least on my screen, yes?
Yes, I'm still here. Having trouble with my mute button, though.
Not to worry. What I want to say is I have observed as we've gone through this challenging exercise together, it is my responsibility, as I see it, to keep pushing on you all, and to exhort and to expect high level of performance even as you work under increasingly difficult conditions. I hope you understand that in no way diminishes my respect for and appreciation of your efforts. So as I continue to exhort, and I hope that I will continue to express thanks on not only my office's part, my part, but obviously on behalf of the folks I represent. I know, for example, that standing up the Mountain View facility is no small effort, and but I think it will pay big dividends in terms of the health and safety of the public. So thank you for all of your efforts, and thank you to those of you who work with you. We turn to Supervisor Ed Lee and see if there are any other comments or questions at this time. Supervisor?
Thank you, Supervisor Median. So my comments, I guess, echo what I have previously said, is that given the fact that one of the challenges is about getting the vaccine out in terms of ramping up our capacity to provide vaccination, and that 6,000 number certainly is very exciting that we've been able to accomplish at this point. I certainly would say that we would, my suggestion would be to avoid dialing down our capacity, given the fact that it is something that is so important to try to get out as fast as we can, and not try to reserve the second dose as much. If one thing, the federal government is not doing the second dose, they're not playing that game anymore. They're going to give us all the dosage at one point, right? So, and we really have to really hope that the new administration, given the promise of the president-elect, the president tomorrow, saying that the 100 million people will be vaccinated in the first 100 days, I really do hope that that through these dramatic numbers that we expect to see in the future, that we were able to continue doing that to get the vaccines out as fast as we can. As my understanding is, as much as we want to schedule people to be done on that day, if they were like a week late, a few days late, certainly it's not going to be as crucial as just having vaccines sitting around. So my point basically is that I would like to err on the side that we are running out of the vaccines to get that to as many people as we can. I think would be the goal I would hope that we are trying to accomplish. And especially if luck has it, that's a larger allocation start showing up suddenly, right? And if that were the case, then we certainly are able to continue on the ramp, or even ramp up to 7,000 to 8,000 doses a day. That would be really, really exciting. But I certainly would say for all the great effort you guys have been doing in terms of scheduling 6,000 a day, I would certainly caution against doing that and try to just get those doses out as fast and as safe as possible. Thank you.
Thank you, Supervisor Lee. And Dr. Smith and Dr. Cody, just in closing, I think I want to underscore one point, and that is, if it is the county's position that we simply cannot, by virtue of the vaccine distribution, accept the responsibility to provide the vaccine to patients of Kaiser or Sutter, then I think it's going to be incumbent on us to make sure that we are working with and pushing on Kaiser and Sutter to get the vaccine out to their patients. That's the inescapable conclusion I reach if we're going to be in a position of telling folks that they can't get the vaccine except from their provider. Yes?
Yes.
All right. Thank you for that. And I joked earlier a little bit about the fact that everybody wants to design the dashboard, but I do think in addition to showing the relative level of distribution by healthcare organization, indicating what percentage of the county's population folks have a responsibility for, will help the public understand more fully where reasonable expectations are being met and where they are not. So I'll just let it go at that. Thank you. Supervisor Lee, I'm going to ask for a motion to receive the report. If you're amenable, I will then second it, and then we'll see if there are speakers on this topic.
Thank you. Still moved.
Motion by Lee, which is simply to accept the report, receive the report. I will second. Let me turn to the clerk and see if we have anyone waiting to weigh in on this subject.
There are no speakers.
All right. No speakers at this time, then please call the roll.
Vice Chairperson Lee
Aye.
and Chairperson Simidian.
Aye.
Thank you very much.
Motion carries 2-0, and the report is received. Thank you all again. Takes us to item number 7, which is to receive the report of the County of Santa Clara Health System relating to community-based health clinics. And I believe that we're going to turn to Mr. Santiago, to our Deputy County Executive, to start us off. Yes, Mr. Santiago?
Yes, yes, and good afternoon, Mr. Chair Simidian, and welcome. Supervisor Lee, look forward to working with both of you as we advance the health and well-being of our communities here in Santa Clara County. This presentation is done jointly with our community health partnership partners. So it includes Dolores Alvarado, who's CEO of the Community Health Partnership, as well as Luisa Abuada, who's the CEO for Ravenswood Community Clinic. They will also be part of this presentation. Plus, Michelle Delacalle, our Director for the Office of System Integration, is available if we have further questions. Just briefly, our written report provides a little bit of background for purposes of laying the context of our community clinics, which we consider as part of our core community network as a health system. It gives a little bit of the history, principally for Supervisor Lee's benefit, but for the general public as well, in terms of how this partnership has evolved over the last several years, particularly under national health reform, of linking payment to performance and health outcomes. How our community clinics, as well as we have in the system, adapted a variety of different processes and contracts to align to both federal policy as well as state direction. And so we also provide a status update on some of the what we call waiver-related programs that have been a way for us to leverage local funding to expand access to primary care, as well as to improve the care coordination across our systems and build a better system of care. We give a little bit of snapshot view of where those both the funding and the utilization stands. There's obviously variations in terms of the numbers, given that most of our programs are based on claims-based data, and it's a snapshot picture at a certain point in time. So undoubtedly, our work with our clinics in a collaborative way continues to make sure that we are transparent and we share data back and forth. So that way, all of us are working collaboratively in terms of where we stand at any point in time in terms of the implementation. We also recognize that the long-term opportunity here and shared commitment is to make sure that we have a sustainable and viable safety net here for our community in Santa Clara County. And so upon your direction, we started the strategic planning process that involves not only the community clinics, but more recently extended the participation to our local initiative, the Santa Clara Family Health Plan, where we've been able to identify certain high priority strategic items that we want to work on. And I gave a little bit of a brief report in terms of that status after a series of several strategy sessions. So without further ado, I think Dolores has a PowerPoint presentation, I believe, and I think I'll turn it over to her unless you have any specific questions to me at this point.
Go right ahead. I think, Supervisor Lee, this is one of those times when it would make sense to hear from everybody up front before we weigh in with comments or questions. Is that agreeable to you, sir?
Absolutely.
Great. Then we'll go to Ms. Alvarado, and just so the clerk knows, I'll also, once the presentations are done, ask for public comment at that time from any and all interested parties, so that we have it all out on the table before we begin our discussion. So I think I'm turning now to Ms. Alvarado, yes?
Yes, good afternoon, everyone, and Supervisor Simidian, thank you for inviting us to present. And special welcome to Mr. Supervisor Lee. It's a pleasure, and we look forward to working with you.
Thank you.
Renee, thank you for the introductory comments as well. I'm going to start out with just a couple comments to add to what Renee said about our planning process. We had, honestly, we had envisioned starting in the spring to the summer, and then we had a COVID situation, so we had to postpone it till the late fall, early December. We've had two very robust sessions, and we're going to be going into a third session. And what's come apparent that before we can go into huge visioning, which we have started, about what it looks like, what is a safety net system of care looks like, and who are the key stakeholders, we had to address some pretty painful administrative issues that were kind of lingering, over the last couple of years, both on our end, Santa Clara Family Health Plan's end, and Valley Health Plan, as well as a little bit of HHS regarding PCAP. So we're in the process of figuring those out. They're not exciting pieces of information, that you may want to know, but I would like you to know, to the board, is that if we don't fix things like appropriate allocation of lives, making sure that providers are credentialed in a timely basis, making sure that the data that we are sharing is in fact accurate, because if it's not accurate, then it leads to decisions that are not very good, right? So it's my job to look at the non-exciting things sometimes in order to get to the exciting things. So we're now in the process with Valley Health Plan, Santa Clara Family Health Plan. We formed a committee. We will be looking at each issue one by one. Renee, we may even start touching on PCAP, and then connect with you so that you can hear what our group is thinking about. And then we'll get to the very real deep strategic visioning of what it looks like to have pretty strong partners, the health plan, Valley Health Plan, Health and Hospital System, Valley Medical Center, and us, and what our future looks like, certainly for the next 10 years or so. So thank you for that. The other thing I wanted to share with you, that in addition to our meetings with Renee, Dr. Smith, we also meet with Dr. Smith. And I do that in concert with Silicon Valley Council of Nonprofits and the Behavioral Health Association. We meet with Dr. Smith, with Miguel, with Keeley, and those discussions are having to do more with what's going on with the budget, what's going on with the $200, $300 million deficit. It changes every time we meet, right? There's a new piece. So although a big portion of the discussion has to do with behavioral health and social services, it impacts primary care because our patients use those services as well. So that's going very, very, very well. Particularly the last meeting we had was quite fruitful. There's a lot of information that's going back and forth between the entities. The other piece of information I'd like to share with you has to do with our advocacy groups and sort of all the advocacy that we're doing to hopefully get the governor to listen to our perspective of why it's so important to have vaccines come into our county in a timely and fruitful basis. And we're asking the governor to really look at this situation from the lens of equity, racial injustice equity. We have done a great job in government of talking about equity, and we sign lots of forms, right, about how we are socially just. So this is a time to prove it, and this is the message we're giving to the governor. So I'm hoping that we can join you in your advocacy efforts as well for that same population. Indian Health Services has been very good and has allocated over 1,100 doses to Indian Health Clinic, and they've vaccinated 1,100 people. They're now into the second dose of Moderna. So we see how they have been able to do that, to allocate, from a racial, ethnic, trauma perspective, and that started even before we started to vaccinate. Which brings me to testing and vaccination, which I would like to share, particularly Supervisor Lee, we haven't had an opportunity to meet yet. So we started tracking testings back in late October, early November. We're up to about 2,500 tests. It may not seem like a big number, but it's a very concerted testing effort, meaning right to those zip codes where we see the hardest hit and the mortality rates. And to show you, the last group that was done in Mexican Heritage Plaza, they had a 26% positivity rate. I mean, that's way over the top. So it's where we need to be. It's not a huge number. The context is that we have to continue flying the plane and changing the engine at the same time. Our utilization has dropped, but I'm really quite pleased and proud and surprised that they're still going on. People are still coming in. People are being seen telephonically or Zoom. So even though it's dropped, it hasn't dropped to zero. And Luisa will give you more information about that. So very impressed with our staff. Let's see here with vaccines. We vaccinated over 1,400 staff last week or week before. And I do want to take a minute to thank Dr. Jennifer Yoon and Dr. Fensterschat. They were really, really wonderful to work with, to have us look at the variety of ways that we can come together. The number of tests, the number of clinics that are on the chart that Dr. Cody shared, you don't see every clinic, and it's because they came together, they paired up. So one clinic received the vaccines, then they brought staff from another clinic. And I thought it was, actually quite beautiful to see that partnership come together. And it really made it easier for Dr. Yoon to distribute the vaccines. So that was good. Let's see here. Let me give me one tiny second. So one last comment is that in the document that I prepared for you, Supervisor Simidian, which is very long, single space, 11 pages, but I also figured that Supervisor Lee would enjoy reading everything that the clinics do, every contract we have. A couple of other things. The contracts for fiscal year 21 are still being negotiated. We're meeting with Renee, I think this week, Renee, on Thursday.
Right.
We're meeting with you, and we have been meeting with him regularly. So he can give us updates on what's going on with whole person care, the advocacy that they're doing on behalf of whole person care. So now that we know that whole person care has been approved, at least for one more year, I think now we're ready to finalize those contracts, is my understanding. I've also shared with Dr. Smith that we are true partners with him. We know that the rest of the county, the rest of the departments are going to have to take some sort of a hit. And, we want to be, let's see, how do I say that without volunteering, giving away all our general fund? But just know that we appreciate having discussions with him and with you, Renee, to show the value of the clinics, but at the same time, also be partners with other nonprofits and support them in whatever way we can. And then lastly, we have learned a lot during this pandemic. Most of you know that I come from public health. This is not my first event. This is my fourth. Started out with 911. And one thing I learned early on, and I would like to see that continue and up for your consideration, supervisors, is to ensure that the community clinics have a seat up front when, cross our fingers, we don't have to go through this again, but I know we will at some point, that they have a seat at either the EOC or in the public health preparedness structure. Once we were given a designated person to work through, who was Brian Darrow, we saw a big change in the EOC relationship, in the allocation of PPE. That took a while. I think that if we're at the table, not only will we know what's going on, we will have input, but more importantly, we will be a backup to you. We will help you do a better job as a team. So that's something for consideration. There is a seat, I believe it's for cadre, which represents primarily human service, social service type agencies. The medical clinics would, of course, bring the medical perspective, clinical perspective. So for your consideration, we would appreciate that. And along those terms, we've also had lots of discussion about what could we do in the next emergency, earthquake, et cetera. How else can we play a role in helping the county exercise their responsibilities? And one could potentially be having clinics that are overflow clinics, so designating them as urgent care. Depending on the type of pandemic, this one took over the hospital, another one may take over shelters, et cetera. So those discussions, I think, would be really fruitful. We hope to bring them back to the strategic visioning, but also wanted to let the board know that that's something that I think would be helpful. And there is a precedence. A couple of our clinics have done this in the past, particularly Indian Health. And we use the incident command system. We understand all that. So that might be something to consider. And then my last comment has to do with PCAP, the infamous PCAP, which is the program, Supervisor Lee, for the residually uninsured. And Renee, in your report, you speak to it, and we're in full agreement with you. We all came to the table in good faith effort to have a program that would serve the uninsured, that would be financially, that would make sense financially. And then we started to make it a Medi-Cal-like program, and we had 4 agencies, including ours, plus the clinics involved in this. And I think we had perhaps one too many chefs in the soup, and it really turned into a little bit of a, mess, frankly. So people are being seen. There's no question. There's about 2,300 folks, between 23 and 25 enrolled. I know Renee and I had a dream. What was it, Renee? 5,000 up front immediately. And I actually thought, oh my God, that's nothing. Well, we've never reached it. Certainly the federal administration had a lot to do with that. But that's not the only reason. There were some administrative barriers. So hoping we can put our heads together and really come up with something that makes sense and that is sustainable and that encourages people to come see their provider. So with that, I guess we'll take questions later, right, Supervisor Simidian, or comments you said? Yeah. So I'd like to introduce, may I then introduce Luisa Boada, who is the head of Ravenswood Community Health Center.
Thank you very much. Ms. Boada, welcome. And Ms. Boada, there we go. Thank you.
So thank you for the opportunity to present to you this afternoon. I'm Luisa Boada, the CEO of Ravenswood Family Health Network. And also nice to meet you, Supervisor Lee, for the first time. So Ravenswood Family Health Network, we added network. We were a health center that started 20 years ago in East Palo Alto. And in April of 2020, we actually acquired the Mayview Community Health Center sites, which is one in Palo Alto, Mountain View, and Sunnyvale in District 5. And so I guess I should just ask you quick, Supervisor Simidian, I know you had a couple things on that you wanted me to talk about, and I just want to make sure that I don't go off in the wrong direction. Did you want an update specifically about both the transition of taking on Mayview and Medi-Cal transition? Oops, you're muted.
Thank you. Yes and yes, and thank you. I think since you've given me this opportunity to insert myself in the conversation, Ms. Boada, what I would say, yes and yes. And as part of that, I do want to just let you know I'm looking forward to some follow-up today on the sort of bigger picture challenge of getting to the folks that Ms. Alvarado described as the residually uninsured. I think certainly Ms. Alvarado knows from conversations we've had over the years that that's a priority for me. I think you know that as well, Ms. Buada. So if you can make sure we fold that into the conversation, that will be helpful and important. Okay?
Okay, sounds good. So we actually had a very quick sort of a dating and a marriage relationship that had in 6 months from September of 2019 to April of 20 to take over the Mayview sites. It was an acquisition, and we moved all the staff over, all their benefits, all the patients over, all the contracts over, and the county, Jeff Smith, and the folks, Paul Lorenz and Greg Price, and all the people who were involved in signing contracts did a very great job in moving them all over. So on April 1st, essentially everything was under Ravenswood Family Health Network. And the intention was that we would, one day the patients were going to be, and the staff were part of Mayview, and the next day they were us. And that did happen. And it happened successfully. But it was also 2 weeks into COVID. So we also were in the process of switching to Epic in July, and it was a 18-month process, so we weren't about to stop that. So we had to bring the Mayview sites over as well, and everything associated with doing that, which included, buying complete new technology equipment for them so that they could be in the same system with us. So that went really well. We had fortunately had a chance to meet people and start developing a good rapport and communication with the staff. There were 76 staff, only 3 did not come over. So 73 of them came into our organization. So then what happened afterwards? So I also want to tie this to community health partnership in that I wanted to point out that, we have been meeting, as Dolores said, regularly to talk about partnership values, strategic priorities, a lot of really excellent dialogue. And I think overall, I just want to say that progress is being made on some of the substantive practical issues. Because where I sit as the CEO, we're trying to deliver healthcare and get paid for it. And there are many practical challenges that we have in working with Santa Clara County with Valley Health Plan, Santa Clara Family Health Plan, and then to the extent that HHS has the contracts for PCAP, whole person care, and GPP, there is also the administrative challenges exist across those 3 organizations. And although one of the things that I just want to add is that when you transition a healthcare organization over to another, for Medi-Cal, the state has a role. And so the state approved the transition in June, but did not put us in a computer system until August. So we could actually not bill. We could not bill Valley Health Plan. However, we went ahead and credentialed, all of our providers through CAQH, which is a credentialing program. And we believed everything was fine. And then starting in July, when we were trying to get ready, we were testing the new Epic billing system, we started running into issues which we didn't understand why it wasn't working. And so this is kind of the list. The large areas there are credentialing issues, there are patient member roster issues. Because of the credentialing issues, we then had specialty access issues, and then of course we didn't get paid because of it. And so I would say that we were working through staff, and we finally had a great meeting in December with Laura Rosas, Deborah Holliday, and their staff, and they admitted that they are restructuring. They'd added many new employees. It was a very positive meeting, and we had 4 areas we were looking at, which is those that I just mentioned: credentialing, patient member rosters not being the same between Valley Health Plan and Santa Clara Family Health Plan, specialty access, and outstanding claims. So we divided them up and we've been working on them and we're making a lot of progress. And my staff, I check in with them every couple of weeks and it's going very well. But it also points out the complexity of these issues. So I'm going to summarize first, and then if we want to talk about some of the examples, I will. But I'm going to summarize where I think we need to go. And I think this also is very similar with some of the other community health centers. When we've had meetings among ourselves and to some degree directly with Valley Health Plan, Santa Clara Family Health Plan, and administration, these have come up. If we are going to solve these are very practical issues that need to be solved. At the end of the day, we need to have metrics, measurable outcomes. That includes making sure that credentialing and NPI information for both Valley Health Plan and Santa Clara Family Health Plan are identical. Patient rosters between the two health plans need to be identical. We would like the P4P measures for the same disease conditions and preventative care to have the same definition, so we're not, doing extra work. Update provider relations checklist processes to assure that a provider, in this case, we were coming on essentially in some ways as a new provider. We had a Valley Health Plan contract, but we were coming into the system in some ways for the first time. And we need to have a specialist representative work with us to help us walk through it, because trying to call and email one person who didn't have power to do a whole lot to help us took months and months for anything to be resolved. The other thing, the state AB 2674 in 2002 passed a law that said that all patients assigned to a federally qualified health center would not be assigned to individual providers. That continues to be a contract issue. It does provide extra work for our staff because every time a different provider sees the patient, although it's allowed, you have to look up their supervising or assigned physician or in the organization to add them. Otherwise, the claim gets denied. And then it gets paid eventually, but it does provide extra work. And then we also need to improve the coordination between HHS contracts for PCAP, whole person care, and GPP with Valley Health Plan that actually does the payment. Because, for example, in December when we had our meeting, Valley Health Plan had never received the signed contracts that we signed in March. So they didn't know about that. So we were wondering why nothing was moving forward, and it was because they didn't know they thought we didn't have the contracts. Plus, by that time, by December, we not only had assigned the contracts from the previous fiscal year, but had signed new contracts. So we ended up sending them to Valley Health Plan. So clearly, and I realize there's COVID and all these other things going on, that it's been challenging. It would be great to have a current contacts and a provider manual that would help us, because a lot of it we've had to run into obstacles and then sort of work through trying to figure out why they were obstacles, as opposed to having a manual. And some of the examples that I can give is, in terms of credentialing, and some of the stuff, I have no idea how this happened. But when we started this credentialing work group after the meeting in December, we found that every single provider, every single one of our 46 providers, names were misspelled in the credentialing roster. And that was one of the reasons why claims were being denied. And they said our providers weren't credentialed at Santa Clara Family Health Plan. That's an example. And it's being cleared up, and we're down to, we've got 2 more people that we need to straighten out. But, I don't know if that's somebody moved something over in a computer and the computer did it, but it just seemed odd because I can't imagine someone just making that mistake, that many mistakes. But because of that, it affected our referrals because we could not use Valley Express. We could submit a referral, but we couldn't see an outcome for our patient. So we didn't know if the patient had an appointment or not. And so there was a lot of difficulties in managing our specialty care because our providers weren't credentialed properly. So after that meeting, also, we met with folks from Santa Clara Family Health Plan, and we found no less than 41 errors between the credentialing between Valley Health Plan and Santa Clara Family Health Plan and Valley Health Plan, which we're working on. And right now we're trying to work on the Valley Health Plan and getting that straight, and then are going to go back and clean up in Santa Clara Family Health Plan. So we're working through them, but part of the point of bringing these up is that, you know, all of the issues around credentialing, and for example, Santa Clara Family Health Plan doesn't have our correct NPI still. And I know we've submitted them over and over again, but so we don't know why, but hopefully when these things get corrected, whatever the communication links that broke down are broken, that we can actually improve the process so this will not happen again. Because it shouldn't just be that we get our thing fixed. It should be that the process gets fixed. So any clinic and anybody and any provider could go through signing up for either one of these plans and not have to encounter, you know, item after item after item where, you know, we're all trying to individually figure this out. Currently, we don't have a common patient roster. When we first, in April, all the patients at Mayview got a letter notifying that their doctors were no longer working and part of the plan, and we had to reverse that. So we sent a letter out, Valley Health Plan sent a letter out. We don't know why that happened. The patients still came to us. And you know, we were talking about also seeing patients who are uninsured. 50% of Mayview's patients are uninsured, and we see them. We see them regardless of ability to pay, particularly now. I mean, we have to charge a nominal fee as an FQHC, and we don't require that. If people need to be seen, we see them. And frankly, we don't send people to collections. We also, you know, we don't harass people, but we do bill them because we must. And, you know, if after a certain period of time they can't pay, it gets written off as bad debt. And we know under COVID, this is going to be a bigger issue for us in the future. A lot of people won't be able to pay, but that's what we're there for. And we're going to keep seeing people, and we will provide access to care irrespective of all of these challenges. But it would be great that we wouldn't have to spend so much time working on these kinds of things. It'd be great if we can solve them once and for all, because some of these are longstanding. And then, you know, in terms of specialty care, we do care very much for our patients to have access close to home. A lot of the complaints our patients have is that they have to go all the way down to San Jose to get their care for specialty care. And many of them want to go to El Camino or they want to go to Stanford. And of course, they aren't being approved for that. But then when you don't have access, so until January 8th, there was no dermatology access at Valley Medical Center. And then the providers who were on the list, they weren't accepting our patients. So we had a big challenge around dermatology until this month. For the first time now, we now can get our patients in because there's a new contract with an outside dermatology group. Right now, ophthalmology has no access. And so we are working, we started inquiring if we have optometry, excuse me, medical optometry at our clinic in East Palo Alto. So many of the things we can do in-house, but we have to get a VSP contract through Santa Clara Family Health Plan. So we're working on that. But anyway, these are some of the examples and things that the challenges, and I don't want to get too far in the weeds, but we appreciate how much attention that the leadership, Jeff Smith and Renee and Laura and Christine, also at the Family Health Plan, are giving the health centers to try to resolve this. I think everybody has a very positive attitude about wanting to make this work. And I think as long as we keep in mind what that success looks like, and make sure that we have work groups outside of the strategic groups to work on these things, I think we can get there. I mean, these are solvable. So with that, that's my report.
Thank you very much. Just one quick question before we go forward. And again, I do want to try and hold off on questions and comments, but Ms. Buada and Ms. Alvarado, the sort of logistical, administrative, data entry kinds of problems that you were just describing, which I understand are key to making the system work and to getting payment for services, are those specific to the Mayview Ravenswood dynamic, or are those across the system? You're on mute, Ms. Alvarado.
They are very much across the system in varying degrees. And I'm honestly, I think what's happened over the last 3 years, so we started working on this 3 years ago, is that we get pushed into, think big, think 30,000 feet, you know what I mean, from a 30,000 foot. And so we've made the mistake of adhering to that, and that never gets you where we need to go. And so now I have refused to totally stay up there. I want to do both. And that's what Luisa's talking about. And finally, how we were able to move that needle a little bit is when I started to see that if the provider name isn't spelled correctly, that costs Clinic A so much money, whatever that is. So now we have people's attention on all sides of the field. And so to answer your question very briefly, it's across the system, varying degrees.
Thank you. Let me see, are there any others who are going to present on this before I turn to the clerk and ask for public comment? Ms. Rosas, I see your screen popping up and I see your smiling face. Do you want to weigh in here a little bit before we go to questions and comments from the public, or excuse me, comments from the public? And you'll need to unmute yourself. There we go.
Okay, thank you. No, I just want to thank, everyone for being really cooperative. There's obviously things that we need to work through as a system. Healthcare is really complicated. Provider directories are always an issue throughout healthcare. And, we just need to work together and resolve these. And we had a good meeting this week, and actually this morning, in working out a cadence of meetings and how we're going to move forward to really, because these are really, they're data, they're very practical issues. I mean, one of the issues with healthcare is that you do need to telescope from 30,000 feet down to the weeds. It's a weedy industry. There's a lot of details, there's a lot of data issues always. And so I'm really encouraged by, working with Lisa and Dolores. I think we've had some really good conversations and a good path forward. And I appreciate their support and patience.
Okay, thank you for that. Anybody else in the way of a presentation? Either I'm looking to the team here. If not, we can go to comments, if any, from the public. Let me turn to the clerk and ask, do we have folks queued up to speak on this item?
There are no requests to speak.
All right. Supervisor Lee, would you like to lead off?
Yes, I can. Actually, I do have a follow-up questions that you mentioned. This idea of credentiality of the providers, basically the misspelling of provider's name, it seems something so basic, right? So basic. It just really looks to me as a data entry problem. But of course, it just cascade into, hundreds of claims probably denied just because of one misentry. Am I correct, understanding this correctly? Is that how that started, or where do you think those problems came from?
I really, that I just found out from my staff this morning because it was just recently discovered. So I don't know, because we would never send a list of misspelled provider names. So I can't, and because it was 100%, I have to think it is a data issue, because I could see someone making, being a little dyslexic and making an error here and there. So it must have happened along the way, and no one realized that was an issue. so I'm glad we caught it because that's fixable. But it does, because it cascades into every aspect of everything we do, or even the NPI number, the provider, I'm trying to remember what NPI stands for to tell you, but anyway, the NPI, it's a provider identification, national provider ID. You can't get paid without that. And so, if that's wrong, you're obviously not going to get paid correctly. So I know that we are sending in our numbers correctly. So it's a mystery to me. Why?
Yes. And Supervisor, if I may add,
Yes.
this is something that I think is, as both Luisa and Laura indicated, it sounds something so simple that should be very streamlined, but it is complicated because for the private sector, the only NPIs that could be assigned are physicians. And so if you go to an insurance company, and then of course they assign you to a PCP, for example, like in Kaiser and other systems, and that's an issue even at the state, because a lot of providers take on a lot of contracts, but they only have very limited physicians, and therefore people have problems accessing care when they don't keep track of these things. So over time, the state has developed and promulgated not only rules and regulations around these things, but also requests for information to make sure that providers don't overextend themselves and then leads to access issues. In this particular case, FQHCs have a special provision that allows them to assign them to a clinic. And then the issue of equity comes into play as well, because, okay, if I go to a clinic, I may see different providers, whereas if I go to a private, I see the same provider. So I think it's always one of these complications that seems at the surface very simple to fix, but then underneath it, as you peel the onion, it becomes very complicated very quickly. And that is the fragmentation of our system that we have to deal with, where we have different funding streams, where we're trying to patch together a variety of different programs and try to do it as seamlessly as possible when you have multiple actors in a variety of different tech, push and pull, in some cases contradictory, both goals as well as regulations. And we try to make the best of it, even with COVID, as you just heard, try to make the best of it here as a local healthcare system. How do we actually provide universal care, universal access, and ultimately the timeliness that we all desire in terms of the care?
Thank you, Renee. I think this is exactly what Ms. Alvarado was mentioning. This is not exciting or sexy stuff, but this is exactly what it takes to get things done. It's unfortunate that we have to, instead of doing the big picture to deal with it, but it's like, sometimes in life, there's no shortcut out of it. That just have to, it's a tedious operation, but it needs to be done. Otherwise, the bigger problems would continue. And then the other issue, of course, is about this common patient roster, whether there's a way, sometimes it might be just having, a couple of tables and run it on some type of a comparison of names and just run by, misspelling of people's name, of course, with all the ethnicities that we have, that certainly also causes more problems too, right? The spelling. And of course, once you got misspelling and bam, the system kicks it out. So I don't know what system that we could provide on our end, IT side could help. But I certainly would like to make sure that these are the type of things that, if the process is broken and it's fixed, right? These problems will keep coming back. So I think fixing the process at the end of the day would be so important. Not that I have any solution to it, but I certainly am glad that you are highlighting the problems and that we bring it up front, and it's just that, and hopefully we could jump on board and fix the process at the end of the day. I think that's the important part, so that we could eliminate all of these type of red tape problems. Because when you guys don't get paid, bad things happens throughout. And of course, by not getting the proper paperwork, we're not getting reimbursement from the state or Fed, so that's not good for us, right? So it doesn't really serve anybody that way. So, okay, thank you very much for the point that you have stated.
Let me jump in here a little bit, supervisors. all of the issues that have been described are being worked at in groups with the individuals that can help solve the problems. But just to put things in context, during the time period of the last 5 years, 6 years actually, there have been constant changes in the healthcare field in Medi-Cal, Medicare, covered California. First ACA was on, then it was off, then it was on again, then it was off again. Each of the health systems, or I should say each of the HMOs went through different upgrades of different IT systems. Rules changed, regulations changed. There's just been a whole lot of change in the environment. And although, it's very unfortunate that all of these problems occurred, I do think that we have the forum at this point to solve them, and we will solve them. And I think, we've committed to meet in appropriate operational groups with the people at the table who know exactly what's happening and who can actually solve the problem. So it's frustrating, but it's going to get solved.
Thank you. Thank you, Supervisor Lee, and thank you, Dr. Smith. A couple of comments and questions. First, I want to go back to Supervisor Lee's closing comment, and I think it's the opening comment from Ms. Buada, and that was, you want to do two things: provide health care and get paid for it. And I think it's important to say, lest anyone think that that's a mercenary take on all this, our ability to continue providing health care to the neediest among us depends on our ability to fund that health care, which is why it is so important that that funding is forthcoming from the state and federal sources that Supervisor Lee referenced, and that Ms. Buada, I believe, was referring to when she said, hey, we just want to provide health care and we want to get paid for it. So that is the indispensable ingredient. And to Ms. Alvarado's comment, there's a sort of a 30,000 foot view, but at the end of the day, what makes that real is the practical administration of the system on a day-to-day basis. If it breaks down there, the theoretical notions and the aspirational notions are just that, theoretical and aspirational. I will say, just to sort of put my frame around all this, and for those of you who were kind enough to attend the State of the County address that I gave a couple of years back, when I talked about healthcare, for me, the vision is simple and challenging, which is I want every single resident of Santa Clara County to have access to quality health care. Period, end of story, full stop, whatever you want to say. How that happens is the subject of great complexity, as Ms. Rosas mentioned earlier. Some of you may recall at the time I quoted Walter Cronkite, who said, I don't know why we call it a healthcare system. It isn't healthy, it isn't caring, and it sure as hell isn't a system. So, trying to weave together all of these different programs is the task you all have taken on, and thank you for that. But for me, if you sort of say, look, bottom line it for us, my concern is simply that every single person in this county find a way to be provided the health care that I believe they deserve and are entitled to. So I want to underscore the importance of figuring out what comes next on PCAP, because to go back to that program that Ms. Alvarado described as being for the residually uninsured, Ms. Alvarado and Mr. Santiago, I believe, we're talking about folks who, by virtue of their economic circumstance or their documented or undocumented circumstance or some combination of the two, simply are not able to make any of our other systems work for them. Is that a fair summary? And if not, please correct me.
That is
Correct. That it is completely, absolutely correct.
Yeah.
It's really an economic and financial status.
So we've got, folks who are blessed, fortunate to have good health insurance and good providers here in the county. We've got our VMC system with the 3 hospitals and the 9 clinics out there. We've got the community clinics who are doing the work. But, we know that as hard as we try, that we, struggle to get that last 2, I would call it maybe 3 to 5% of folks who are still without coverage or access. And so I want us to keep pushing to get there. And I think that's the contextual framework for the conversation. But as everyone has alluded to, okay, now comes the hard part, making it work as a matter of practicalities. I guess Dr. Smith and Mr. Santiago, Mike, I'm going to sort of put everybody on the spot on purpose here. My question is the county organization committed to continuing these conversations until we wrestle these, critical, albeit sort of pedestrian issues to the ground successfully?
Yes, we're committed to do it, and we're going to fix it.
Okay. And Ms. Alvarado and Ms. Buada, your organizations are committed to wrestling these issues to the ground as well?
absolutely.
Okay. So, Supervisor Lee and I have the easy part of the job today, which is to say, please keep doing it until it gets done. And the hard part of the job will be yours. And Dr. Smith, I want to put the most positive face I can on this. Virtually everybody on this meeting or call today has heard me more times than they care to reference the fact that of the 9 primary care clinics and the 3 county hospitals that we have, none of them are in the 5th supervisorial district. I should acknowledge here that Dr. Smith has been very good over the years about saying, hey, if there's an opportunity for us to provide services in that area that makes sense, we would pursue it. And unless that's the case, we understand the importance and the need of working with folks in the Community Health Partnership and others to make sure that the community-based care is there if we can't make it work. So, Ms. Buada, I'm looking at you right in the eyes, and I'm thinking of our friends at Planned Parenthood as well. You all are key in my district, and since my district's right next door to Supervisor Lee's district, we're both looking at you. And Ms. Alvarado, lest you think I am forgetting you, I am not. I want the same throughout the entire county for everyone, but I am underscoring how critical it is, even though the need may be less in my district, for example. When you got 0 in the way of county presence, then it becomes particularly acute. Now, that being said, we don't have 0 in the way of county presence. We've got dental clinics that are coming online. And now I can't see if Mr. Lorenz is on the call yet. Mr. Lorenz, are you with us?
I am with you.
Thank you. There you are. So I guess my question is, as we are pursuing space at the Planned Parenthood clinic in Mountain View, and we have talked about offering services there that are complementary, is that a conversation that you're having with others, including Ravenswood, to sort of talk about what kind of specialty care might be available in the North County to address the point that Ms. Buada raised earlier, which is it can be a challenge for people to get themselves down to San Jose for the specialty care that they could be referred to if only it was existing someplace a little bit more practical and convenient.
Supervisor, those are conversations we are looking forward to having to make sure that we are clear in terms of what services we can provide to the community together.
Okay, so forgive me if I'm sort of doing this in real time with the whole world watching, including the folks who are on the call. But Ms. Buada, I don't know how much you're aware of the conversation we've had with your counterparts at Planned Parenthood, but we have acquired from them not 1 but 2 spaces on the same mini campus there in Mountain View. We've talked about providing services that are complementary rather than competitive with the folks at Planned Parenthood. It seems to me, as the other key player with facilities in Palo Alto, Mountain View, and Sunnyvale, we should be talking to you about saying, all right, what is the bundle of services, specialty services in particular, that makes sense if we're going to have a sort of, I'll call it a North County cluster of county services that complement both your services and Planned Parenthood. So I just, if that is a conversation yet to be had, I hope folks will have it before decisions get made that lock us in. Okay?
Yeah, absolutely. Would like to be at the table.
Okay. And Mr. Lorenz, thank you for, seriously, thank you for your willingness to bring yet another partner to the table, because I know the more folks we bring, the more complicated it becomes, but it also means we can do more with more folks sitting around the same table. We haven't talked much today, and I want to ask if we can close with this, mindful of the time left for the other items. Where are our community clinics in the vaccine distribution program? Let me go to Mr. Santiago or Dr. Smith or whoever would like to lean in on this one from our organization.
I can talk to it a bit.
Thank you.
We've distributed from county public health some vaccine to the clinics, and we're working with them to try to expand that. I'm not on the working team. Marty is. I can show you what's been happened so far, which is online. But we're also looking at some clinics to do higher volumes than just their own patients. And so, for example, I think Gardner is going to be setting up a higher volume site at the Mexican Heritage Center. They've already started doing that. But the community clinics are a critical part of the county system. And once we've got a system where we have adequate supply of vaccine, we'll be expecting and partnering with all of the community clinics to provide vaccine to their patients and to anybody else who qualifies.
Thank you, Dr. Smith. I'll just say, I think all of us are anxious about the fragmented system for delivery of the vaccine and whether or not it will prove effective. But ultimately, it's the system we've been handed, and we're going to have to find a way to make it work. And so I do think that, we're in what I would call the all of the above place where we're going to have to use all of the partners that we have available. And we may say, well, we can, get more done at a mass distribution site like the fairgrounds or Knockwood, the Mountain View Community Center or Berger, but we're still not going to be able to reach everyone we need to reach unless we work through our community health partnership and those clinics as well. And, where they have relationships that will allow them to make the connection, I think that's going to prove indispensable, even if it turns out, and I don't know if it will, but even if it turns out to be a quote smaller number, in order to get to the number that we're looking for, 75, now 80, now 85% in terms of countywide immunity, I think that's going to be key. And thank you for putting the slide up to show that they're engaged in that way.
Supervisor, may I add to what Dr. Smith said?
Please.
Yeah, thank you. So I mentioned earlier that you don't see all the clinics here. It's because one was the recipient while another clinic just sent their staff over. So that was very successful. Yesterday, we had a planning meeting yesterday morning about who's, regarding mass vaccination, and mass can, for us can be as little as 300 all the way to 1,000. So there are 3 groups that are at this point planning to come together, different parts of the county. The other piece is probably even as important or more is that we meet with Dr. Fensterscheib and Dr. Jennifer Yoon every Thursday morning to do the planning together with them. So that's how we were able to get all our staff vaccinated. And then starting tomorrow, we are deploying 14 community workers to surround the Mexican Heritage Plaza in the morning, letting people know that that's opening up at noon for vaccination on Thursday, excuse me. So there is a plan going on at this point. As soon as the vaccines come, the clinics are getting ready as we speak. Indian
Thank you very
Health is
much.
vaccinating on Wednesday. Okay, thank you.
Thank you.
I should also point out that the Pfizer vaccine is not a particularly, great vaccine to be able to do this with. So once we have more Moderna or AstraZeneca, we'll be in much better shape, being able to do many more sites.
All right. Thank you. Then what I think I will do, mindful of the time and the need to get through some other important items, is ask Supervisor Lee if he's ready to make a motion to receive the report.
Thank you, Chair. Yes, I am, and so moved to receive the report.
I will second that. We'll ask the clerk to call the roll.
Vice Chairperson Lee.
Aye.
And Chairperson Simidian.
Aye, and we'll say unanimous. And I will just close by exhorting the staff and the Community Health Partnership folks to stay in the mix, keep meeting, keep talking, resolve these issues. They're, as you point out, issues that can be resolved, and we need them to get resolved so that you can deliver health care and get paid for it. And then again, Ms. Boat, if I can impose on you to and Mr. Lorenz to make sure that we have the conversation about how we can bring some perhaps limited but nonetheless helpful specialty services to the North County that might make sense for the 400,000 folks in that part of the county, as well as some of them in Supervisor Lee's district as well, I suspect. Thank you for that. Have a good day. Stay at it. We appreciate what you do. That takes us to item number 8, which is the SAFE program report. And let me ask who's going to present that one. Mr. Lorenz, do I start with you or do I go to Ms. Walker?
Thank you, Chair Simidian. We can move directly to Ms. Kim Walker.
Okay. Ms. Walker, welcome.
Hi, can you hear me?
Loud and clear. Thank you.
Perfect. Well, good afternoon, Supervisor Simidian and Lee. My name is Kim Walker. I am the nurse manager of the Santa Clara Valley Medical SAFE program, Sexual Assault Forensic Exam program. We see the patients who are 12 and older, adults and adolescent, who come in for medical care and forensic care after sexual assault. You have the report today that summarizes our actions. We are primarily going to talk about what we've been doing since our last report to you in June of 2020. So by July of 2020 last year, all of the new coded positions that were approved by the Board of Supervisors have been filled. These new codes have created a core management staff that can flex between covering our SAFE program needs and providing coverage for exam needs in a larger capacity than previously available. Since June of last year, we've continued to also work on the number of SAFE examiners that are available to support the program service expansion. Currently, we have 18 active SAFE nurses and 3 staff that can provide the exam care. We also have 12 trainees who are expected to be independent by March of this year. Training has been impacted by COVID restrictions and factors related to the pandemic. Examiner training at the state level has also been reduced and then revised to online training only. This has eliminated the hands-on skills training that we need and push that responsibility onto exam teams to develop curriculum and complete that. Our program's been working on new strategies to that end, including simulation training to overcome kind of the limitations that we're facing with the ability to gather, the access to nursing training locations, and the availability of the live model teachers. We're also looking at grant funding opportunities for innovative technologies to see if it can support our simulation training goals. We've also had impact on our training because of the reduction of cases in 2019. After we've kind of had a 10% year-over-year increase in the number of patients we were seeing, last year there was a 6% reduction, and it was primarily around the months of shelter in place and then the last 2 months of last year. The first and third quarters were actually quite busy for us, but those two were much not as busy for sure. With respect to our response coverage in Santa Clara County, we continue to base our program at Valley Medical Center, which is centrally located in the county. North County, where we primarily respond to the emergency department at Stanford Hospital. But we have also performed several inpatient exams there for patients who could not be transferred due to medical reasons. In 2020, we did 29 cases at Stanford, which equates to about 7% of all of the cases that we did last year. We also are seeking to create a similar response in the South County at St. Louis Hospital. We, as you may remember, had planned to begin our response there in April of last year, but it coincided with the dramatic increase in COVID cases, and we stopped our efforts to respond there and delayed it. We actually had a phone call today with administration there. We are hoping we'll definitely be open in 2021, but we are going to meet with administration there and look at some alternative locations nearby that would hopefully allow us to open up sooner rather than later. We also are planning to respond to the Child Advocacy Center near O'Connor when it opens later in March this year. Our response there will be somewhat limited because the pediatric exam team will primarily operate at that location, but we will augment that with those patients who are 12 and older who need an acute exam. With respect to our safe response outside of the county, in August of 2020, we successfully opened up a location in Santa Cruz County on the Dominican Hospital campus, and we do have access to the emergency department there. This has been the result of a strong collaboration with the Santa Cruz Sheriff's Office, their dispatch, Dominican Hospital, and their outside pharmacy, their law enforcement agencies, and of course, Valley Medical Center administration. We have done, last year, about 12% of our cases came from Santa Cruz, but interestingly enough, about half of those were done in Santa Cruz after we opened there. So the last 4 months were about half of the cases for the whole year. We also provide services to San Benito County. We have done so for all, most if not all of the time that we've been in existence. There is a draft agreement being finalized. It's going to include our South County response. So it will be more specific to the response that we intend to have rather than what we've provided in the past. And that will replace the MOU that San Benito has historically had with us. Last year, we did about 1% of our cases for agencies in San Benito, but I can tell you that we've already exceeded that in the month of January. So additionally, our expansion efforts have focused on services beyond our training and our expansion for response. We've been participating in a strangulation pilot to evaluate whether or not our medical forensic exams have benefit both to the medical needs of survivors and any investigation or prosecution for cases where there is no sexual assault. That is going to be updated separately to the Children, Seniors, and Families Committee in February, but the results are quite good, actually. We also have been working with the SART committee in the county to develop a database that will essentially provide a single platform so that all the data from the responding agencies can be aggregated into one single source and then used to identify any gaps or areas of improvement or areas of success within our SART response overall. Another example is because we want to make sure we hear from the survivors, we have designed basically a SART survey so that we can utilize that to understand from the survivors where we can strengthen or improve our response to survivors in Santa Clara County, and they can base that on their experience in the county when they had to utilize that. That survey actually went live in the last few days, and it's, I don't have a slide for you, but it's available at www.everyonesafe.org. And I believe the supervisors have all been provided that information. I know Supervisor Chavez just posted it recently today. So that is what I have. If I have any questions, I'm happy to answer them. And Andrew Berlini is also on this call.
Thank you very much. Supervisor Lee, I'm going to lead on this one if you can bear with me for a moment or two. first to say thank you to Ms. Walker and Ms. Berlini and Mr. Lorenz for their work on this effort. And I know the thanks goes beyond you to, others who have been working with you in this effort. So thank you to you all. I'm really gratified to know that we are delivering these services in the North County area now, as well as at VMC and in Santa Cruz County. I want to come to South County in a minute. I will say I noticed from looking at page 5 of 5 in the staff report, which is packet page 47, where it talks about the response in Santa Cruz County. It looks to me like the numbers indicate pretty clearly that if the services are available close to home in a familiar surrounding, the number of folks participating goes up rather dramatically. Am I reading those numbers correctly? Ms. Walker, I can start with you.
Well, I can't completely determine why. I would say yes, the numbers do support that. It also is the benefit of the rape crisis centers are able to have an in-person response if they're on that side of the hill.
Yeah. Thank you.
On the Clara side, it's not.
And that, of course, takes me to the question about South County. So what has to happen, and by when do we think it will happen, so that we are delivering these same services in South County?
It will be determined on a location that is suitable. We want to make sure that it provides somewhere that is safe, somewhere that is patient-centered, confidential, and it has the ability to be cleaned in a way that we need to have it cleaned for evidence purposes. So it needs to meet those criteria, and that's what we're going to be looking for when we meet with them, hopefully next.
And let me ask you or Ms. Berlini or Mr. Lorenz to lean in on this. I mean, are we fairly confident that such a space can be found in the next 6 months? It's just a question of looking and figuring out what the right space is, or is there some concern that hard as you might look, you'll come back and say that there just isn't anything that fits the requirements of the program?
If I may, Supervisor, there is a clear commitment by the administration at St. Louis Hospital to find a solution to this. So I'm somewhat confident that we can find a solution within the next 6 months.
All right. Mr. Lorenz, you may remember better than I when the next report back on this program comes to this committee. Do you happen to remember? I don't.
I don't. I think we agreed to come back to this committee every 6 months, I believe.
Well, we'll ask you all your team to report back on the South County success story, I hope, in that next meeting, please, okay? And really do want to, through the administration and through your good offices, emphasize the importance. I think the results in the North County that you've been able to deliver in Santa Cruz County tell us that unfortunately the need is there, and that the presence of these services will make a difference in terms of who and how many folks will be able to access them. Let me also ask Ms. Walker, the reference to moving the training programs online brought me to one of my on the one hand, on the other hand observations, which is, on the one hand, I'm guessing it may not be as robust a training as you might like. On the other hand, I know what struggles you had getting training scheduled. Does this mean that some of those problems in terms of getting things scheduled have been, if not eliminated, at least mitigated somewhat?
To a degree, there's some new problems, but we are overcoming them. And I think we've successfully found a path through it, and we've had some really good training outcomes.
Okay. There was some information about both the success story of bringing new staff on and why that's been helpful and important, but the challenges of maintaining the current levels of staffing in the existing positions. The report seems to suggest that you think you can meet those challenges. Did I read that right?
Yes.
All right. And I guess the last question I would have for you or Mr. Lorenz or Ms. Berlini is there anything that our county or our board needs to do to help you bring this effort to, you know, an absolutely complete and successful conclusion? Mr. Lorenz, I'm getting the look from Ms. Walker that says she'd like you to answer that question. That's my read.
No, I think we've been very fortunate that the expectations in terms of how the program should be implemented and provided to the community, it's been clear. Your guidance and the board support has been a key to that success. And I really do believe that within the next 6 months and as we come out of this COVID situation, that this program and this service is going to be invaluable to the community.
All right. Well, I'm going to ask my staff to reach out to Ms. Walker about passing reference to the fact that some education and optimization are ongoing to improve appropriate utilization of the North County site. I take that to mean that maybe just a gentle reminder to some of the Northwest County law enforcement would be helpful. Knowing that everybody wants to be collaborative and work together, that just old patterns, you know, sometimes take a while to change. And so we're happy to work with you and your team to make sure that we spread the word and remind folks that the services are available should they be necessary. And I forgive me, I do have one more observation. Ms. Walker, you referenced a survey that piqued my interest because one of the questions I had scribbled down for myself is, what are we doing to make sure that the provision of these services is informed by the experience of survivors? And I thought I inferred from your last comment or two in your opening remarks that was a significant part, the reason for the survey. Did I infer correctly?
Yes, we wanted to make sure that the survivor's voice was involved in anything that we were going to improve. We have our own opinions about what could be improved, but we really want to hear from the survivors.
I think that's very wise. And did I understand you to say that the results are back now?
No, it was just, it went live last week, late last week. We will have it open through the end of February. Depending on how it goes, it might be open a little bit longer, but we want to see what kind of input we get and how robust that is by the end of February. I can tell you that it's been amplified throughout the health and hospital system. I know that EMS put it out today too. It's been on all the social media, so you may see it in a number of venues.
Well, pleased to hear that. I do want to ask my staff to work in cooperation with you all to make sure that when we have the results that I have the opportunity to give it a careful look, and I know you'll share with all 5 offices. Not to put too fine a point on it, but I know it can sometimes be a little difficult for folks who work in the county to be advocates for their own program or for resources, and having the opportunity to review directly the observations of survivors in terms of what they believe is most needed will be helpful. So thank you for that. All right. Thank you, Supervisor Lee. Comments or questions from you?
Thank you, Supervisor Smithian. Yeah, very good report, and thanks for the news about these positions being filled and that the trainees will become independent soon. So that's a lot of folks, a dozen folks coming on board. That's great. On the issue, on the pilot program that you talked about, can you hear me okay?
Yes.
Okay, good. On the pilot program, the report says it is to begin on January 2020, a year ago, and then you had some procurement work in February 2020. Has that already started a year ago, or is this something that will happen soon?
The pilot program, we started doing those exams on January 1st of 2020.
Uh-huh.
The procurement process for the database, which kind of is an adjunct to the survivor survey,
right?
That is in the middle of procurement process. It's quite a ways through the procurement process. We have a vendor that we would like to select, and so it's hopefully going to be built and implemented this year.
Okay, so I think it's probably a typo in the report. It says February 2020. I think you meant 2021, correct?
It looked like that might be the case, yes.
Okay, all right, just clearing it. Okay, so the other part is just more of a personal question, understanding. So the idea of this program is to examine survivors of strangulation that has not accused of sexual assault, but you figure that if they have strangulation, they probably have been sexually assaulted. Therefore, that's why you were trying to do the examination as well. Is that what we're talking about?
Not quite. What we want to do with these exams is follow the lead of San Diego and Alameda counties, because strangulation is prevalent within intimate partner violence and domestic violence situations.
Right.
There is a definite benefit to doing these exams, both for the medical health of the patient, but also for the forensic investigation and prosecution of the cases. So we're just going to see the benefit of it outside of the sexual assault exams, which we use these exams for.
Right, great. Now, you mentioned San Benito County. Do they have their own facilities at all, or they just rely on us completely?
They don't. By law, if you have under 100,000 people in the county, you do not have to have a program, but you do have to have a plan. And
Wow.
so because they are well under that number, their plan is usually to partner with us.
Right.
We are closer than the county.
Right, but you mentioned that there really isn't something in St. Louis yet, right? So the closest facility would be where? Here at VMC?
Yes.
Wow. Yeah, from San Bernardino. No, from San Benito, driving to VMC without traffic is what, 2 hours? Easy. No.
I can tell you it's 50 minutes door to door without traffic, but with
When's that?
traffic, it'd be much longer, yes.
Yeah, exactly. So as far as St. Louis, you said you see that sometime this year. The problem, I guess, is location, right? Because of space issue.
Yes.
Yes.
Right, yeah, so absolutely, the need is of well, for that reason, we need it for South County, we need it for San Benito, so certainly the quicker you guys could get this put together, that would be great. And the last question I have is regarding CAC over O'Connor for pediatric. You mentioned is for 12 to 17, right? How about the really extreme cases, like for even younger than 12 years old? Are those being handled somewhere else?
Those are going to be handled by the pediatric exam team. We're two separate teams. They will see the younger age population.
Also at O'Connor's as well?
It won't be at O'Connor. It'll be at the Child Advocacy Center, which is next to O'Connor, very close to it, but they will be
right.
attached.
Okay, so basically it's all there. If any kids issues, that's where they go. Gotcha. Great. All right, yeah, that's all the question I have. Thank you very much.
Thank you. Let me just check in with the clerk to see if we have any speakers on this issue.
There are no speakers.
Thank you very much. Then Supervisor Lee, if you're prepared to make a motion to receive the report, I would be happy to second.
Thank you. So moved to receive report.
Motion to receive, second from Lee, Supervisor Simitian seconding. Mr. Clerk, please call the roll.
Vice Chairperson Lee.
Aye.
And Chairperson Simitian.
Aye.
Thank you very much.
All right, motion carries, and thank you again to the whole team. Much appreciated. Be well. And that takes us to item number 9, ambulance wait times. And Ms. Lowther, are we going to turn to you for the opening presentation here?
Yes, sir. How are you?
And all is well. I am going to ask you and your colleagues to be brief and just respond to questions after you give us just a brief remark. I know you know how important I think these set of issues are since we've worked on them together for years, but I'm mindful of the time and want to try and make sure we get to other important items on the agenda. Okay?
Will do. Good afternoon. Just very, very briefly, all providers have met compliance standards in November. We do not yet have December performance as they have not been finalized at this particular time. All inquiries surrounding exemptions pertaining to hospital wait times will be evaluated collaboratively with the providers. And so, as you can tell by the report, that all hospitals dealt with continued increasing volumes for both inpatient and emergency departments throughout the fall and in December. So at that same time, EMS volume also increased. So we'll be happy to take any questions that you have on everything. And I'll turn it over to you, Supervisor Simitian.
Thank you. Let me just underscore a point, and please clarify or correct if need be. We've been in touch about some of the wait times, which are also called wall time, in terms of the challenge of transferring patients from the ambulance to the hospital. And I think it's important to underscore that's important to our ability here to deliver good services, not only because it works a hardship on the patient in the ambulance, but for every minute, hour, hours, plural, that the wall time extends, that's time that the ambulance can't be out on duty serving the rest of the county. Do I have the basics right there?
Yes, sir.
Okay. And my understanding is we have some challenges because given the fact that our hospitals are managing the COVID crisis, that has aggravated the issue of waiting time, wall time in a significant way. Is that a fair summary?
That is a fair sum.
That being said, you seem satisfied for the most part that folks are managing this reasonably well under the circumstances, but that we have had at least a handful of occasions at some of the hospitals, not county hospitals, but hospitals within the county serving our patients. We have had some incidents where the wait times have been well beyond what we would hope for, yes?
Yes, sir.
So what are we doing? What do we need to be doing to eliminate even those outliers? And is it being done? Has it been done? Let's cut to the chase on that one.
It has. I have sent reports on a daily basis to all the hospitals on any previous daily ambulance patient offloads and work with those hospitals that are having any significant issues. In December, it was an extreme challenge. And so discussing with their hospital administrators as to what plans were they putting in place. And in January, there's been a significant change. Of course, volumes have leveled off and things are, let's say, just a slight bit better. But it's a matter of gauging almost on an hour-to-hour and daily basis as to what is actually occurring at those hospitals. And those same hospitals are doing much better on their offload times, but it is managing almost hourly.
Thank you. I know we have what I consider at least a fairly complicated set of protocols for determining when a hospital bypass is necessary or appropriate, when we should take somebody to another hospital than would otherwise be the case just because they are backed up as much as they are. Do you think that system is working as well as it can and should at the moment?
It is, and we haven't had to institute some of our mitigation strategies, but we actually look to see what hospitals are holding ambulances for an excessive amount of time. And for us, we start actually calling both administration after 45 minutes, we start calling the hospitals. We send a field supervisor over there at 45. We start calling hospital administrators, or at least the ED charge nurse, the ED directors at an hour. If we have more than 2 ambulances for greater than an hour, we look, and the system is impacted. And that what that means is that, you know, we start having calls. Actually, when you call 911, those calls are holding. And if at that point that's happening, we start looking at routing ambulances to other hospitals. We've only had to actually institute that on one occasion since, you know, the later part of December, early January. So we do have mitigation strategies that we can put into play. We have a couple that we're working on with county council. So we look at what we as a system, EMS, can do to help facilitate the hospitals along the way.
Going back to the challenging days that you had in December, where there were some very long, limited number, I know, but still very long wait times, was that, in your assessment, was the system working as well as it could and should at the time, or was there some flaw in the system or the administration of the system?
At that moment, on that day, I think the hospitals were so impacted, and we had not yet instituted what we call the SDO 21, which I just mentioned, and should have instituted that earlier. And on that particular day, we had sort of a domino effect of low system levels along. What I mean by low system levels is our ambulance capacity out in the field was also low. The hospital capacity was limited. There was inability for that particular hospital to transfer, and multiple hospitals were also impacted. So we had multiple domino effect of not being able to transfer and get more ambulances out at the same time. So
thank you. Thank you. Is it fair and accurate then to say that we moved to a different approach in part based on that experience?
yes, I would say so.
Okay, so that experience was an indicator that, okay, our existing protocols need to be tightened up even a little bit more with these other approaches that we have available. What about surge tents, which I know is a suggestion some have made? What's your take on those? I don't feel well enough informed about their potential to know if that's a good idea or not a good idea.
All hospitals have surge tents and are using them. Only one does not. Another one has a surge tent and hasn't put it into use yet because of staffing. So I think so far they have worked out very well for almost all of the county.
Okay. Does that mean that the hospital that doesn't have a surge tent should be encouraged in some way to get on that program?
We have been working with them on a process for them to utilize that tent. Their question is, how are we going to staff that surge tent?
No, understand. Facilities is only part of it, and the staffing is key. Thank you. That's helpful information. The only other thing I'll say before I turn it over to Supervisor Lee is, as you can imagine, it pleases me to look at the San Jose numbers in particular and see that they've achieved their 90+% timely arrival rate month after month after the time and energy that we put on this some years back. So please convey congrats to them as well when you talk to them, and also let them know I'm looking at them every time you bring a report. Okay, so thank you for that. Supervisor Lee, on this item.
Thank you, Supervisor Minion, on this one. Looking at the table, San Jose is now at least 91% and more. Certainly has room for improvement, but certainly better than what it used to be. And it's interesting from the table too. Various places like Santa Clara and Mountain View seems to do very, very well. While, Sunnyvale's next is like 95, about less than 95, and Gilroy as well. And San Jose is the lowest on that end. Looking at this thing called the ambulance bypass, I guess I'm a little bit concerned about how those numbers has gotten that bad in December, especially at VMC, which we have far exceeded that 36 hours up to like 55 hours now, and even regional well in the month of December. Is that, you see, is that all related to the latest surge in COVID that's causing these huge number coming up?
Bypass is a management tool for the hospitals, and when their load sort of exceeds their capacity, and for VMC especially, it really is important to note that their capacity is very limited, and so they have the highest volume of patients they receive from the EMS system. In addition, they also get a very high volume of behavioral health patients. So due to EPS also having low capacity due to, that also decreased this last year due to social distancing. So for them, they're trying to avoid the surge that they get, and this is the management tool for them. For regional, their policy was always to never go on bypass, which is part of the issue that got them into trouble into December. They weren't going on bypass, getting totally overloaded and letting the ambulances just wait outside. And so they said, we convinced them that they needed to go on bypass, or we would put them on bypass. So they finally said, oops, maybe we're accepting too many, and then they're sitting on the wall for 2, 3, 4 hours. So it is high, but we would rather they do that than have the ambulances sitting outside for extended.
Absolutely. Yeah, good. Okay. And yeah, as far as that's the only questions I have there. Thank you very much, Jackie.
Thank you, Supervisor. Can we get a motion to receive the report?
Yes, so move to receive the report.
All right, and I will second. Let me check with the clerk, see if there's any public comment on this item.
There are no public comment.
All right, and I will ask the clerk to call the roll.
Vice Chairperson Lee.
Aye.
And Chairperson Smidian.
Aye.
Thank you.
Motion carries 2-0. Thank you very much. That takes us to item number 10. And Mr. Santiago, we're running a little long here, but I want to try and make sure we do justice to all these items. So for those who are listening, concision would be appreciated, but I still want to make sure we cover everything as fully as we need to get the job done. So please begin.
Yes, and thank you, Mr. Chairman and Supervisors. We have two just items that I wanted to bring to your attention on my written report. One of them is the issue about the 1-year extension. That's good news. It allows us to obviously continue the services, keep the primary care teams intact, whole person care, those projects that we just talked about with the community clinics, and then of course have an opportunity for the Biden administration to look and work with the state in terms of what to do next. And then the second piece is telehealth, and this, it's important. We're encouraged by the governor proposing to make telehealth permanent for our county, across the state as well. And this is something that, as you know, we've been working closely with the clinics to extend e-consults to make sure that specialties are available by electronically. And of course, we've been able to scale those capacities right now under COVID, and it's the primary way of how we're doing primary care through VMC and the ambulatory care clinics. So those are the two things that I want to conclude, and unless you have any questions, we'll move on to the next reports.
Please do.
The next one is from our public health officer. I don't know if Dr. Cody's still on.
I think we've covered those items earlier, so thank you. Let's go right ahead.
And Paul Lorenz is next of VMC.
Thank you, Renee, Supervisor Simidian and Supervisor Lee. I'll be brief, and I think Supervisor Simidian, you had mentioned your your priorities are the priorities of the county. And as a healthcare system, we continue to focus on access and capacity for our patient population in the community. But also, again, we are also focused on testing and vaccination, and we all know the importance of that to the entire community. So that is something we're working very closely with the county EOC and the public health department. That is the major priority and push for our organization. So with that being said, I'm happy to answer any other questions that you may have.
Let me just quickly ask you, there's a reference to the $500,000 county grant for services for cancer patients, working with and through the Pink Ribbon Group and the Cancer Care Point, matching funds from nonprofits. Anything else you want to share about that that effort? As you will recall, that was my push during the budget process, and so I have a particular interest in it. I'm sure that comes as no surprise to you.
It does not, and the good news is that they did provide a certification because it is a matching program, and so the program continues to move in the right direction, and we're looking forward to this continued partnership.
When do you think it might be appropriate to ask you for a report back with the folks from those two organizations about the nature and extent of the services being delivered?
March or April would be fine.
All right, then I'll work with my staff to find a time on the committee agenda for March or April, and we look forward to a report back. Okay, thank you.
Thank you.
And Supervisor, go ahead.
To Paul, I know that he's very comprehensive, extensive in his report, but one thing I wanted to make sure that I raised to both of your attentions is on page 61, HIM stage 7. If you remember, right before COVID in August, we had launched the electronic health record, a best-in-class system for both O'Connor and St. Louis. Paul and the TSS team have been able to not only roll that out successfully, but achieve stage 7, which only very few percent across the whole U.S. achieve in terms of the utilization of the electronic health record. That's a huge achievement, given everything else that everybody's doing in terms of COVID, as well as obviously vaccinations and testing and a variety of other things. Significant accomplishment by our team.
Then what I will do, Mr. Lorenz, is say congratulations, but then I will add 3 words, which will not surprise you. Privacy, privacy, privacy. All right, that's all I needed to add on that one. But in all seriousness, congratulations.
Thank you.
All right.
And then the next report is from our Director of Behavioral Health Services, Sherry Terrell.
Hi, good afternoon, Chairperson Simidian and Supervisor Lee. Sherry Terrell with Behavioral Health. We just had a couple of updates in our report. One being that we opened in December, toward the end of December, a new behavioral health motel, and this was really to support the discharges out of the emergency psychiatric services. And so we've developed a contract with the Fontaine Inn. We currently have about 9 patients staying there with the support of county operated services, as well as one of our vendors, Telecare. The other highlight I wanted to just bring to your attention, which we have been sharing on an ongoing manner with the Health and Hospital Committee, has been related to our new innovation project, Community Mobile Response. And so since the latter part of last year and even through the beginning of this current calendar year, we've been conducting many public listening sessions, gathering input, really wanting to hear from those in the community about the best way to structure and set up that program. So that's ongoing. We plan to convene a work group, including the Mental Health Services Act Stakeholder Leadership Committee, as well as our Behavioral Health Contractors Association. And then finally, we offer a status update on the mental health programs that were implemented in fiscal year 2020, and those are really focused on our more intensive services. So I'm open to answering any questions you might have. And we also have a couple of staff people on the call. I understood there may be an inquiry from a past report with respect to suicide prevention, and so we're able to answer any questions you might have.
Thank you. I'm going to ask, when is Alcove going to open in Palo Alto, and when is Alcove going to open in San Jose?
We are scheduled to open in, let's see, I would actually have to get back to you with the definitive date, but we're looking at what I understand to be March and April.
Mr. Rao, I'm not putting this on your shoulders. I know you've inherited a lot, but definitive dates seem hard to come by on this project. And as I think you know, this is an issue I have been working with staff on for more than 5 years now. So could I ask, today is Tuesday, could I get a definitive date that's real on both facilities by close of business on Friday, please?
Yes, we will provide that to you, Supervisor.
And, you know, I know there are other things going on out there, but we've got kids who need the help. So I know you know that, and I'm sorry to push on you, but I'm frustrated and I'm at my wit's end that this thing keeps going longer and longer. And every day that goes on is a day we're not delivering the kind and quality and extent of services that we should. And Supervisor Lee, forgive me, I don't mean to be precluding you from any of these conversations. So you're just going to unmute yourself and chime in as we go, if you like, okay?
Yes, thank you. The question I have right now is regarding your mobile response team. You're saying you're getting more public input right now. And how is that program going? And what do you expect all these input will be finished for the next step?
Yeah, so we are wrapping up our community input sessions. We intend to be able to bring the work group together during toward the end of this month with a plan to be able to come back to the board. It's my understanding in March with the plan finalized and developed with the work group and the input of the Stakeholder Leadership Committee and our Behavioral Health Contractors Association.
Okay, very good. Thank you. And that's all I have.
Thank you. Then let's go on to the next item. Mr. Santiago, I'll let you continue to walk us through the subset of items here.
Next, we have our CEO from Valley Health Plan, Laura Rosas. I think we can't hear you.
The dreaded double mute. My apologies. Thank you, Renee. Thank you, Supervisor Smithian and Supervisor Lee. I'll keep my comments brief because I know it's late. Cover California will continue to be open for enrollment until January 31st. We are about between almost 23,000 enrollees. Given COVID, outreach is still difficult. So our outreach is generally digital and social media, and it has been successful so far, and we'll continue to do that. Cover California at the state level has done a lot of ads and a lot of outreach, and we're looking forward to the new administration and their continued support of Cover California and the Affordable Care Act. We've also really expanded our case management, especially our complex case management. We had ended our relationship with our vendor in the fall. We had spent most of last year developing our case management capabilities, and I'm proud to report we have taken that on, and we will continue to improve and make those functions more robust. And that is, unless you have any questions, that you have a lot of the data on our operations in the report.
All right, thank you very much. No questions at this time. And moving on then, Mr. Santiago?
Yes, you already heard from Jackie Lowther, EMS, so we're moving on to Dr. Day, who will give you the update in terms of a reorganizational plan for custody health services.
Okay. Good afternoon, Supervisor Smithian, and good afternoon, Supervisor Lee and Supervisor Lee. I'm glad that we had the opportunity to have a meet and greet. And this is just a brief overview of the city, the salary ordinance, the reorganization plan for custody health services. I'll be submitting that plan to the Board of Supervisors in February. It's a plan that projects a net savings to the county general fund. And I have meetings scheduled this week to meet with the bargaining units as well as with labor relations to work through some of the projected questions around the plan, especially around some staff reorganization. and I'll also be meeting with ESA. And just to wrap up really quickly, the plan will it'll answer the federal consent decree deliverables. It's a very thorough plan. We examined the entire healthcare system, a delivery system for custody health services with SWOT analysis, process and procedures, Lean Six Sigma processes and procedures, scope of practice, work study, workload studies, duplicity, looking at where we could absorb some of the workload. We've done literature reviews, looked at industry standards to include correctional healthcare standards, National Commission on Correctional Healthcare, and National Institutes of Corrections. We also have looked at SAMHSA, especially around the delivery of behavioral health. And so all of these informed a set of recommendations that we will be presenting to the board. And so we're excited to get that plan forward to you. We have some areas that we are looking at establishing a distinct clinical leadership team, creating a whole person care and patient-centered care, streamlining current nursing structure by introducing mixed use of codes, enhancing the capacity of healthcare access to care, and then also looking at discharge planning, that's part of the consent decree, and putting together a dedicated discharge team and increasing the administrative support to all aspects of the enterprise. So that's my report for today. Thank you.
Dr. Day, this is Supervisor Stamidian. I'm going to ask you a question that does not lend itself to a crisp reply, I'm afraid, but I feel compelled to ask it anyway. I feel torn between on the issue of COVID-19 in our custody system. I'm looking at numbers that tell me I think we've had something like 120 new cases in just the last couple of weeks. That's something like 25% of the cases we've seen over the past year. And then I look at the information in the report from you, packet page 73, that says, that we've done almost 3,000 tests and our positivity rate is something like 3.2%, which is, not that bad. I mean, you're pushing for zero, I know, but, when we heard folks from the community health partnerships say they had 20-25% positivity in some community venues, I think, well, 3.2% doesn't sound that bad. And then I contrast that with the 120 new cases in the last couple of weeks, and then I continue to get anecdotal reports of people are telling me as many as half the correctional officers in the facilities not wearing their masks. What's the bottom line takeaway here? A lot of this data sort of seems at odds with itself.
Right. And the data that I'm actually looking at today is from December the 1st through the 31st. Actually, December 1st through the 27th, so it's not a full month. And during this month, we did see a surge as we anticipated, especially behind Thanksgiving. We did see a surge, and so our positivity rate did move from 0.003 to about 3.2%. With that, we have put several things in place. I have actually put a memorandum out that our custody colleagues have followed, that all testing is mandatory. We also started a pilot on our antigen testing. It's rapid testing every day. And so what this is, we will be testing all of our staff every day. We did a pilot to just look at the infrastructure and look at the push through of about 850 staff. And so we have a soft launch this week, and we will be testing all of our staff every day. Part of that also, I put out a mandatory memo as well that we will start wearing all N95 masks. And so we were wearing only surgical masks, and now we will begin wearing N95 masks behind the perimeter in any patient care area. And so those are some of the things we're doing. We did see an anticipated surge, just like the general community, around the holidays, and I think that's what we're seeing now. Today, our numbers are about 106. I did look at for the last 3 months. In our last 3 months, we had probably about over 443 patients that had tested positive for COVID-19. And so today we are at 104.
If I were to walk in to either the main jail facility here or Elmwood, what percentage of the correctional officers would have a mask on?
Hopefully 100%, and that's under the custody bureau. And so they need to reinforce that with their staff, but hopefully we're reaching 100, we're looking at 100% participation. And so I would have to take a look at that as well, but our custody health services are wearing 100% of the masks, and those are distributed on a daily basis as needed.
Well, my sources are, as I say, anecdotal, but that's not what I'm hearing. So I'm just going to ask you as one member of the board to please do your level best to find out what's actually happening, in the facility with folks who are there. And, anecdotal evidence can sometimes be helpful. Sometimes it's just gossip and is wrong. But what I'm hearing suggests that we are not close to 100%. And, I understand that we're working with a population that is in close quarters. On the other hand, it's a closed system. So I'm worried that if folks aren't wearing masks and they're coming in from out in the community and they're bringing the virus with them, that has the potential to make things a whole lot worse all too quickly. Supervisor Lee, can I move on to the next item, or do you have a question on this one?
Yes, I do. Thank you, Supervisor.
Go right ahead.
There's been this hunger strike going on from some of the inmates regarding the health issue that we've been learning this past week after our meeting. First of all, thanks for taking time to meet with me, but I just heard about that right afterwards. And we did send over a bunch of questions afterwards. And I'm not sure you have a chance to get some of those answers, but it's really exciting to see that the daily tests are starting. And obviously it's very much needed. And as we know, inmates are not the one getting the viruses because they can't get out. So it's people from the outside. In this case, we have no visitations anymore. So basically it has to be the correctional staff that's bringing it in, right? So I'm just as concerned, if not more, than Supervisor Smithian when the stories I'm hearing as well is that at least a third, if not half of the correctional staff is not wearing a mask. And I think we made very clear, we do not mandate getting a vaccine. We do not mandate getting tests and outside. In this case, I really think that the tests are absolutely important. And two is, if folks are not wearing masks, what exactly are you doing as the behavioral health director to raise that? I mean, the custodial health to raise that issue up. Is this something that you could do, or is this something that you need to go through the chain of command over the sheriff's side?
As far as the custody bureau, I do meet with Tim Davis almost weekly or every other week. We do have 3 calls a week as well on our huddle for COVID-19. And so I can raise that concern with him. As far as the custody health services, they need to report to work in masks, and those masks are provided in-house. And so the entire time that they're working behind the perimeter in front of patients, they have to have their mask on. And so as far as the custody, I will work with Tim Davis to address that issue.
Okay. Now you mentioned the N95. This is new, right? So before they were just using surgical masks. Now they're moving to N95. And this is something that they use on the daily, like one mask issued per day. It's like a day to day.
They're issued upon request. They do get one mask. We have I actually have a stockpile of masks right now. So we have over ordered so that we have an inventory in place. And these are all sizes of masks. And so if they need a new mask, if it's soiled or anything like that, they can request a new mask. And each nurse manager has their inventory of masks.
Right, and that's only for the staff. This is not for the correctional officers, or not for
correctional officers have also ordered masks, and we've been working with EOC, and so we've also ordered masks for them.
Right, and for inmates, they wear surgical masks then?
Some of the inmates may wear surgical masks. Most of them are cloth masks right now.
Okay, do we have enough surgical masks to give to the inmates at this point? Is that an inventory problem?
I can check the inventory, but we do get those in frequently. And so I can check the inventory to see if we can also supply the patients with N95.
Yeah, if you can give us like an officer agenda memo report later on regarding that issue. As we all know, cloth masks is helpful to stop the spreading, but certainly the surgical mask is way better to protect the individual wearing it. So if we could do that, I think it'd be far safer and helps lower the risk of the spread as well. So I would certainly want to push it up. And regarding this hunger strike issue, do you have any more information about what happened thereafter? Has it stopped or is it still going?
No, it's still going, and I'm getting the numbers every day. We're checking our patients every day. So as of today, we have about 58 patients that are on hunger strike. Some of the patients are beginning to eat, and so we're monitoring all of their vitals on the healthcare side of the house. We're giving them education around dehydration, keeping their fluids current, and taking their vitals. And so some of the patients are eating breakfast, and then they may resort to not eating lunch and or dinner.
Right, okay. And do you know much about the meeting the demands so that they might actually stop this? Or is there any progress in that department?
The meeting is custody bureau is setting up meetings with the patients. And a lot of it is around the conditions of confinement with some of the cells that they're in, that type of thing. We have to move patients around depending on quarantine and or isolation. So we're having to move patients to new units, for instance, to make space for patients that need to be either quarantined and or isolated.
Right, so when people are being tested positive, you have to move them separately to the infirmary or other housing facilities?
When they're testing positive, that's correct.
Right. Okay, so when you say 104, those are 104 that's been kept separate.
104 patients today that have COVID positive, that's correct.
Right, okay. How about space-wise? Do you have more space for it if say the number goes up, or?
We're having to realign every day, and sometimes we have to open a unit. Matter of fact, we have 2 units right now in the women's side of the jail at Elmwood. We open up units there. Most of these patients are going into single cells as long as those are available. And so we're putting those patients in single cells. We work with classification on that. And so the housing classification and the custody colleagues need to make those decisions where they go.
Okay, good. Right, thank you very much.
Thank you. And I think that takes us, Mr. Santiago, to our last report. Yes?
On federal policy, we have Burr Margolin.
Mr. Margolin, welcome. Thanks for hanging in with us through a long afternoon.
Happy to do so. Good afternoon, supervisors. The Biden administration, President-elect's administration, or his team has been busily engaged in preparing on several health issues, and evidence of that, or strongest product of those efforts thus far, was the unveiling recently of his American Rescue Plan, the $1.9 trillion proposal to revive the economy and to battle COVID. There are dozens of provisions in the American Rescue Plan that impact the county and that deal with healthcare, but I'll just highlight, in the interest of time, a couple of them. First of all, there's funding proposed for a national vaccination program, $20 billion, and to sort of contrast the Biden approach with the Trump approach, this would be an effort, a federal effort, to drive vaccination through the creation of community vaccination centers developed by and managed by FEMA, and they also envision deploying mobile vaccination units as well. There's also in this proposal a $50 billion investment in testing, scaling up testing, developing new programs with local governments and with schools for testing capacity. The president-elect also has a proposal to create a national public health jobs program, 100,000 persons to be hired. Initially, they'll do vaccine outreach, contact tracing, and then they're supposed to transition over time into a local public health role, which would obviously impact Santa Clara County and its capacity to do its public health work. The details of how that would be transitioned and how that would work have not been unveiled, but that's worth noting. There's money also, $130 billion to help open schools safely, reducing class sizes, modifying space arrangements, improving ventilation. There's also several $100 billion, between $300 and $400 billion for state and local government aid. This was the controversial issue with the Senate leadership that stopped the last package and ultimately had to be taken out of the package in December. But the president-elect's team has put that money back in, but they haven't given any real specifics yet as to how it would be spent. And it's obviously going to be a contested issue in the negotiations to come. There are also a series provisions in this proposal to deal with health insurance access, efforts to strengthen the ACA, the COBRA program, and the like. So what happens next with the Biden plan? He's got this very ambitious proposal, $1.9 trillion. How does it actually become real? Well, in the midst of impeachment and the chaos in Washington, it will be a challenge. But the first effort they're going to make is to cobble together, if they can, 60 votes to pass this package on a bipartisan basis. If that can't be done with Republican support, their plan is to use the reconciliation process, a process that allows them to pass something through the budget process on a majority vote, a 51 vote basis. Today, the chair of the House Ways and Means Committee is meeting with his members to discuss reconciliation strategy to potentially launch this process in the House. We do reconciliation. The first budget resolution comes out of the House of Representatives. It will take several weeks for this process to work itself through, but there's, again, a reasonably good chance either through a straight bill or through the budget reconciliation process that some element of the Biden package becomes law. Now, who's going to actually implement this program? Just want to briefly highlight the fact that we have our Attorney General, Javier Becerra, who will be soon before the Senate for his confirmation. And if he is confirmed, he'll be a very important ally for California and for Santa Clara County on these issues. And as far as vaccine implementation is concerned, the issue that you spent a lot of time today talking about, the president-elect has selected Dr. David Kessler, the former FDA commissioner, to head up what was once called Warp Speed. They've dropped the name Warp Speed for a range of reasons. They've not produced a replacement name yet, but they plan to have Dr. Kessler, who's very well regarded, the former head of the FDA, the former dean of Yale Medical School. He's going to be in charge of driving this program going forward. So in addition to these legislative efforts, obviously there's going to be a substantial amount of executive action occurring, especially given the uncertainty over how cooperative Republicans are going to be with the Biden administration in moving their agenda forward. On day one, which is tomorrow, we expect the president will issue an executive order mandating masks wherever the federal government has jurisdiction, which would include its properties and also interstate travel. It's also possible that the president-elect will mobilize the Defense Production Act to deal with the shortage of vaccine, something you also talked about at great length earlier today. In addition to those kinds of actions, the Biden administration has already indicated that they plan to re-enter the World Health Organization. They plan to also reverse a whole series of policies that the Trump administration enacted to weaken the ACA. They took away the Trump administration money for outreach, for enrollment. They took away money for navigators who help people enroll in the exchanges. Biden administration is going to restore that funding and make a series of other changes designed to strengthen and shore up the ACA. There were also rules that were passed, like the public charge rule was designed to make immigrants think twice about accessing the Medi-Cal program. They plan to reverse that rule. There's the gag rule involving Planned Parenthood clinics in the Title X program. They plan to reverse that rule. And there'll be a lot else done by them administratively. The last point I'll make, supervisors, involves administrative action on waivers and demonstration authorities. Unclear how much can be done legislatively. We'll have to see in the next several weeks how much cooperation there is. But we do know, in addition to reversing regulations, in addition to passing new regulations, you have the federal government has demonstration authority, the 1115 waivers. There are also these innovation waivers that CMS has access to that can be used to promote policies that would be consistent with the Biden administration's agenda. You could potentially have a state-level public option program created. You could have state-level single payer created through these waiver authorities. There also are waivers, this doesn't apply to California, that have actually been agreed to around the country that have things like work requirements, things that the Biden administration would oppose, and they will plan, I'm sure, to renegotiate those waivers to eliminate those provisions that stand in the way of people actually enrolling in and gaining access to healthcare. So that's a brief overview of what's going on at the federal level. Again, it'll be a very busy several months on healthcare. Happy to respond to questions and comments you might have.
Thank you, Mr. Margolin. Just a couple of quick questions before I turn to Supervisor Lee. The first is, I know all of this is sort of crystal balling and speculative, but if we do see the movement on the package with the $400 billion in it for state and local governments, it sounds like timing is sort of best case end of February. Does that sound about right to you?
I think it's later than that, best case. I think best case is probably more like March, because just the committee, if they do legislation, there's a negotiation that has to go on. I would say March would be best case. And even if in the reconciliation process with the majority vote, they have to pass a budget resolution. They'll probably get by the end of February a budget resolution through, but that's only phase one of the process. You then have to negotiate the details in what's called the reconciliation bill. So all of this is March, April in my mind.
Thank you. And am I remembering correctly that the reconciliation process was the vehicle by which the Affordable Care Act was passed originally?
Yes, it was initially passed as a fallback measure because when they started working on the Affordable Care Act, they had 60 votes in the Senate, and then they lost the 60th vote. But Speaker Pelosi and others had thought ahead, and they had prepared a reconciliation measure with a majority vote that could be used, and that was used.
Thank you. And my last question before I turn to Supervisor Lee is, if I were to ask you, what are the chances there'll be a public option by the end of 2021? What is, and I know you can't tell us what's going to happen, but if you had $5 in the office pool, what would you say?
Well, a national public option or a public option for a state like California, individual states?
I'll let you take $5 bets on both of those.
Well, I think there's a 50-50 shot that somewhere in the country, one or more states decides to pursue a public option, and working with a cooperative administration with Javier Becerra and his team, they figure out a way to do that. Whether Governor Newsom wants to make California one of those states isn't at all clear at this point in time. And as far as actually passing a bill, again, with 51, the Republicans are for the most part resistant to this because it involves expanding, in their view, the Affordable Care Act. So you need to have all 51 votes in the current configuration on the Democratic side. And that's a hard thing to do with the insurance industry opposing. So it's less than 50-50 for a national bill. Not impossible, but very hard.
So does that mean I should infer that the reason for the conversation about state by state is that people are perhaps more amenable to allowing states to go down that path if they choose to do so without requiring that the nation as a whole go down that path?
Yes, and the other way to look at it is you can have Javier Becerra and his team administratively approve, without a vote of Congress, an individual state's plan, at least in theory, with these waiver authorities. And to actually get a bill through Congress, you have the insurance industry, major elements of which would oppose. So that's the difference, having to get the votes in Congress versus having to do it administratively.
Thank you. I missed that administrative authority, which of course makes all the difference in the world. So thank you for that clarification. I'm looking to you now, Supervisor Lee, to wrap us up.
Thank you, Chair. Yeah, so basically it's a follow-up question just to make sure I understand the proposal we're talking about. For most folks have understood as proposed to state and local government, the 300 billion that we're talking about, there's no 60 votes there. It's just not, it's not likely. That's not happening. So but there's basically a backdoor way through the reconciliation process that you explained that if we were able to muster 51 votes, it would take a little bit extra time, but then say by March or April, we actually could get that through. Is that correct?
Yes, there is a backdoor way of doing it through the budget process, but that still involves a difficult negotiation, and it's unclear. There's still issues to be worked through, but yes, there is a way potentially to get it approved without having the bipartisan vote.
Wow.
But the margins are very narrow in both the House and Senate. So even on that kind of package, you need every single Democrat, and a couple of Democrats think the priorities are wrong and that states and localities don't deserve that amount of money, that
Right.
to be blocked.
Right. If Senator Manchin says no, that's it. We're one vote short.
Correct.
Basically.
Correct. Very well said. That cuts to the chase.
Yes. Now, the other point you mentioned, Dr. David Kessler being appointed to head this warp speed, and you're going to change the name.
Yes.
I do know that General Gus Perner is the general in charge of the vaccine distribution. Is he going to still be there? Is he being replaced on that, or we don't know yet?
I don't know that. I don't know for sure. I know that David Kessler, Dr. Kessler, is going to be the overall leader of this effort. He's going to keep some of the old team on as consultants. I don't know every position though.
Got it. Okay. Yeah. All right. And no, it's very exciting to see the public charge going to be, reversed and the gag rule, because as far as I know, the Title X funding for, like, say, Planned Parenthood is clearly affected. So those will likely be restored. And do you think those can be restored even through executive? Can those be restored under executive order, or do they have to go?
No,
through?
you have to actually promulgate a rule, and therefore that's a several-month process. So it won't be overnight, but over several months.
Great. Okay. Yes. That's all I have. It's getting late. Thank you very much.
Okay. Thank you very much. Thank you.
All right. Then I will say thank you, Mr. Margolin, and looks like we're going to have another interesting year, and look forward to having your help as we chart our way through that interesting year, hopefully a better year. And Mr. Santiago, I think you're still with us. I see your cube. Thank you very much. I believe that is everything under item 10, yes?
Yes, correct.
Let me check with the clerk to see if we have anyone who is waiting in the wings to speak to item number 10.
There are no speakers.
Thank you. Then let me ask Supervisor Lee if he will make a motion to receive the report.
Chair, may I do have one off-agenda report request, is specifically regarding the hunger strike. I really would like to find out where we're at in terms of this strike, how it started, what are the demands, and what exactly have the administration, have we met these issues? Is this something that we could potentially get by Friday, Dr. Smith?
Dr. Smith had to leave, but I'll go ahead and consult with both Dr. Smith and County Council to make sure you get the necessary information.
Great, thank you very much.
And Mr. Santiago, am I correct in assessing the situation if I say I think Custody Health will have some ability to provide a report back, but frankly, the Sheriff's Department and Corrections is sort of an indispensable source of information on this issue?
Correct.
All right. And Supervisor Lee, I know you know, but just for the public, the sheriff, of course, is an independently elected official, and that somewhat limits our ability on occasion to access information that would be helpful to have, but we'll see how it goes. I would just, if I may, Supervisor Lee, ask the staff to reach out to the Sheriff's Department and the corrections officials as well.
Yes, absolutely. Yeah. Thank you, Supervisor Smith. That's absolutely the right approach. Thank you.
Then could we get a motion to approve item 10 and the recommendation is contained in our published agenda with that additional direction, Supervisor?
Yes, thank you. So moved, please.
And a second by Supervisor Simidian for the record here. And we'll ask the clerk to call the roll.
Vice Chairperson Lee.
Aye.
And Chairperson Simidian.
Aye. Motion carries 2-0. We will thank you all very much. Without objection and hearing none, we stand adjourned. Appreciate everybody hanging in through a long meeting today. Take care.
Night.
Good night.